Welcome all of you, doctors. Welcome to the TOG webinar. Can we have the slides, please? Today the topic is of COVID lockdown 3.0. What are we going to work on and what are the things which we will come across? Eminent speakers are there with us and I welcome all of you to be present here and witness what things we are going to do in the next lockdown period. Our co-moderator is Dr. Komal Chavan. She will be joining us very shortly. She is the FOXI chair of the Medical Disorders in Pregnancy Committee and also an honorary professor at Dr. R.N. Cooper Hospital. She is a member of the Managing Council MOGS. Next, today we see that in Maharashtra there are 37,136 confirmed cases of COVID and we have got 9,639 who have got cured or they have migrated or got discharged, but unfortunately 1,325 cases are no more with us. And if you see, these are the active cases of the government side where 61,000, more than 61,000 cases are there which have been detected as today of 20th of May. So there are a lot of things which are happening and we have got many meetings which are there. COVID is picking up the pace. We are all stressed up and it's time now to go ahead, and there are so many issues which are there. There are many patients who have been lined up with us for last 2 months and education must go on. It's very important to get to know from our stalwarts, such stalwarts who have come here, Dr. Nozar, and there are world leaders from Bangladesh, Nepal, and we have got also the head of the department of neonatology from Sion Hospital, Dr. Swati. Can I have the slides please so that I can introduce them one by one? Dr. Nozar Shariar, thank you for being here with us. He is the past Secretary General and past MTP Committee of FOXI and he is also the past President of MOGS. He has been the scientific chair of the 22nd FIGO Congress Rio de Janeiro and has delivered more than 16 orations, 500 presentations and FRCOG honoris causa. Thank you. Welcome sir to join us. Next, we have Dr. Rishikesh Pai who will be joining with us. He is a medical director of Bloom IVF Group. He is going to talk also about the IVF and how we are going to tackle this. We have to find out what infertility can be offered, treatment can be offered to our patients now in post-lockdown period. He has got more than 30 awards. He is also the past Secretary General of FOXI and President past of IAG, ISAR and MOGS. Welcome sir. Next, we will be having Dr. Bhaskar Pal. He is there. He is MD DGO and also FRCOG. He is practicing in Kolkata at Apollo Glen Eagles Hospital. He is presently the Secretary of Indian Association of Gynecological Endoscopists and he is to be the President-elect of Bengal Obstetric and Gynec Society, Chair of RCOG. Welcome Dr. Bhaskar.
Thank you.
Next, thank you. I have Dr. Neerja Batla from AIMS. She is a professor there. She is Secretary General of IFCPC, Council Member of ASGO. She was the chair of FIGO Gynae Oncology and we'll be talking about the oncology cases which have been lined up and what are the things which she is going to do. Next please. We have Dr. Rekha Kurian from South India FRCOG. She is a consultant at Joseph Nursing Home, Chennai. She is the past president of OGSSI, Vice President FOXI 2015. She is a pioneer in endoscopy and we will be talking to her about what things will be happening in endoscopy, what is the future of endoscopy in this lockdown period and post-lockdown. Can I have the next slide? Dr. Leela Vyas from Jaipur. She is a senior consultant at Cocoon Hospital. She was a professor and unit head at SMS Medical College and Vice President of FOXI 2018. She has received various awards and we will be hearing from her what is happening in Rajasthan, what is happening in Jaipur and how are they treating those cases and we are going to talk to her too. Dr. Basam Mukherjee will be joining us from Kolkata. He is a FRCOG MD and from CMC Vellore. He is on FIGO coordinator at South Asia Safe Abortion Committee and has been the honorary secretary of Bengal Obstetric and Gynec Society. Presently is the vice president elect of FOXY 2021-22. Welcome, Dr. Basam. Well, we have Dr. Karki. Dr. Karki is from Nepal. He is the chairman of the Virat Medical College and chairman of the Obstetric Gynecology Department. Dr. Gyanendra Mansingh Karki will be telling us what's happening in our neighboring country in Nepal, what are the guidelines being taken there, and what are the prevention methods they have been doing for COVID patients. And we will exchange those. We have Dr. Swati Manerkar who will be joining with us at 6 p.m. And as I said before, she's the additional professor and head of the neonatology department, MD, DCH fellow of neonatology, and we will be getting a first-hand experience about Sion Hospital, which has rocked the nation, where more than 136 deliveries and cesarean section have occurred, and she will tell us about how she has managed those babies and breastfeeding guidelines. Next, we have with us Dr. Laila Arjuman Banu. Dr. Arjuman Banu Laila is from Bangladesh. She is the immediate past president of Obstetrical and Gynecological Society of Bangladesh, president of Bangladesh Perinatal Society, past vice president of SAFOG, and she has got so many designations to her. She has been kind enough to join us from across the border, and we want to hear from all of them. We also thank our pharma partners, MCure, who has been fighting Corona on the field with us, hand in hand, side by side, boosting moral with good words and music. And let's have Shan playing the MCure music for us to build our morale and hear it.
सभी का ख्याल रखते हो, बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो, नहीं जान की परवाह, निकले हो जान बचाने को, तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एनक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एनक्योर करे सलाम आपको। कैसी ये जंग है, बड़ी मौत सांसों के पीछे, बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। महावीर खड़े हैं उन सरहदों की रक्षा में, यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एनक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एनक्योर करे सलाम आपको। एनक्योर करे सलाम आपको।
Thank you so much. I feel so calm and nice and relaxed after hearing that beautiful voice of Shan. I hope all of you agree that that melody, those words calm us, and we are really thankful to MCure to be there with us in this time and reaching out all of us to be there. Thank you all of you being joining us. Now we will be discussing on a very serious note now how to go about and manage COVID. Let's not delay further. And the mic is yours now. Dr. Nozar Sheriar, you will be the first speaker and you will be giving us insight about contraception, abortion, and how do you tackle this situation of COVID in your clinic. And please guide us. Your time starts now. Thank you so much for joining us.
Thank you, Niranjan. It's really a privilege being a part of this panel. And I must place on record our appreciation of Foxy and its president, who really stepped up to the plate when it comes to helping people cope with the pandemic. Now, today's webinar is really interesting because all this time we were talking about being in a lockdown. Of course, since 3.0, we've gone to 4.0. Now we are thinking of the future as to what happens after the lockdown. So these last few months for us have been really something like living fiction. The streets, struggling to work in our hospitals, but now as most countries start making their way back to normal, so we have to in India. Now, India's response with the early and extended lockdown has served its purpose, given that we have less to offer in terms of a medical infrastructure. And, we've been watching a lot of television nowadays, and I heard Ruchir Sharma 2 days ago saying, lockdowns are like holding your breath. There is only so much that you can do without choking. So these lockdowns will have to end at some point. We're expecting that 4.0 will be our last national lockdown, and a life in a new avatar will have to resume for us. So in this webinar, we are going to brainstorm how our professional lives as gynecologists and obstetricians will resume and will change forever. The responsibility I have been given is to talk about sexual and reproductive health and rights. Thank you, Niranjan. And I'm often asked the question, what is SRHR? It seems very confusing for most clinicians. Well, SRHR is everything that a gynecologist does for the woman that he or she cares for and serves, everything. So it's not really confusing at all. But the three key areas of SRHR that I will touch upon today are going to be contraception, are going to be abortion, and are going to be adolescent health services, which are a very important aspect of public health care. Now, there is no doubt that there has been disruption in these areas. And no matter what we want to believe, and I sometimes hear people saying that, services gone on, there was a study published by the FRHS. Friend of ours, Chandrasekhar, has kind of put this study out, which said that in the best case scenario, this is the best case scenario, the lockdown has resulted in a 40% loss of service in March, 100% in April, 75% in May, and expected to lead to a 25% reduction in June. This is the sterilization and IUD services. Every clinician on this webinar knows that there are very few of these procedures that we've done in the last 2 months. Now, what is the consequence? The consequence has been, and these are projections, but I believe that they're actually underestimates, that there are 24.5 million couples that were not able to access contraception, that there are 500,000 less sterilizations, 500,000 less doses of injectable contraception, and 700,000 less IUD insertion. Now, this is a phenomenal figure. And the projection says that we are expecting to have this year 1.9 million unwanted pregnancies.
I recall the first part is good, but the signal very poor. Very interrupted.
1.1 million more induced abortions. So in this situation, we are poised to deal with what has already happened and a lot of work that is waiting to be done when we resume essential SRHR services. So today I discuss with you both our clinical practice as well as the public health situation. And I'd like to start by quoting Peter Drucker, who said that the best way of predicting the future is by creating it. Now, most organizations will do something called as a SWOT analysis, where you talk about the strengths, weaknesses, opportunities, and threats. What I'm going to today is I'm going to talk about a stay on top analysis. We'll just talk about TOP. We'll talk about threats, we'll talk about opportunities, and we will talk about all the practices that we can implement in the areas that I've been asked to speak on. But first, let me speak on a generic return to practice, and I'd like to share with you basically what we've done in our practice over these last 2 months, when we've managed to keep some kind of a practice going with difficulty. The threats to OBGYN practice is that very often sexual health and reproductive rights, though we say they are essential, are not treated accordingly. So let's face it, we've not done our IUCD insertions, we've not done our sterilizations, we've focused on maternity care. Secondly, whenever there is a shutdown, it disrupts our services, it disrupts our supplies. So many of us who keep supplies at the clinic have been unable to replenish them, even if we wanted to, because supply chains had broken. COVID-19 induced a certain fear and concern, and there was delayed care for patients. Patients who needed to come for care put it off, thinking I'll go after the first lockdown, the second lockdown, the third lockdown, and now the fourth lockdown. And finally, we had problem even staffing our clinics, because even if staff wanted to come, depending upon where they stay and where they travel from, that has been disrupted. My concern is, at the moment, everyone is very well behaved. Everyone thinks the best of doctors. I love that video, but I'm afraid that when everything goes back to normal, let's face it, sometimes our patients have not been the most disciplined. They go back to their indisciplined, impatient behavior. They will start walking into our clinics again, and they are going to start crowding our clinics again, and we can't allow this. And finally, of course, when patients start coming back to their clinic, one concern I have is a certain paranoia and a certain judgmental attitude. They will be watching you and your staff on everything that you do. A patient of mine came to the hospital and said, my temperature was not checked at the entrance. What kind of a hospital is this? So we are going to have to be very particular about how we restart our practice. Now, the opportunities are, at the moment, patient compliance is possible. Let's build upon that. At the moment, we are in a position to inculcate a certain discipline and good behavior because there is fear. We have to build up a lot of patient education material, simple things like we read about, we doctors talk about, the public needs to know about, like their basic hygiene, their phone hygiene. We need to plan and build SOPs for our day-to-day practice. And finally, wherever possible, we need to go for virtual consultation. So what are our practices? Our practices start with planning. Before you go to the clinic, there'll be a lot of background planning as to how many appointments you will give and what is the assigned time of the appointments and how much you can accommodate without causing crowding in your consulting room. Secondly, there will have to be a certain pre-visit preparation where you plan your appointments, you do a phone triage, you decide which patient needs to come, which patient doesn't need to come, and give certain instructions. Indian patients very often came with families. They are now told that you cannot come with more than one accompanying person. We are actually going to have to start doing that and stick with it because this disease is not going anywhere. But once this happens, we give instructions and then we can even give them their investigations beforehand so they don't need to give multiple visits, and then they come to the clinic. The moment they come to the clinic, the first thing you have to do is a physical triage where you take their temperature with an infrared thermometer. In our clinic, we now make every patient sign a declaration regarding their symptoms and their background. Now, this may be a little defensive, but remember the authorities are going to be watching you for quite some time, so it's necessary. A very simple written declaration from patients. Patient and personal protection is important, so there has to be signage, very instructional, very clear, requesting them to comply with this in your clinic. Staff and patient to be wearing masks at all time. I keep getting patients pulling down their masks. Unless they have their masks on, do not entertain them. Hand washing and sanitization all the time between every patient. Between every patient, the staff comes and actually is seen to be wiping down the seating, wiping down the tables, wiping down the surfaces, and most importantly, your examination table, which again you try and use disposable sheets if possible. No magazines in the waiting room, no glasses in the waiting room, which can kind of keep the virus going and pass it on from person to person. Coming to the change that we have seen in our practice that some of my colleagues, particularly from other specialties, tell me is telemedicine. And here you can use these modes for one, your appointments. You have to give appointments even for your telemedicine. You have to have a system of being able to charge. You know, today MCI, and there's a lot of change that's happening. Crisis always allows change. We can do a post-operative and post-delivery visits telephonically, and that's what we've been doing to keep patients out. We've had a lot of deliveries, but we tell patients not to come back at this point in time. And of course, you look at the analysis and feasibility. So life as we had has changed completely. There is going to be for every clinic a time to sit, plan, build up a blueprint, write down your SOPs, and make sure your staff is going to completely implement those. Patients and people are watching, and we know how toxic social media can be if there is a perceived lapse in your clinic. Coming to the practice of contraception, here when I look at the threats are that though contraception is important, it is not priority, it can wait. We as it is are struggling with maternity care and the people with other problems, and that's why it tends to be set aside. Secondly, some of it is clinic and hospital based, particularly sterilization, which is the cornerstone of contraception in our country, has just stopped. Public sector, private sector, nobody's really getting into that because our resources are directed elsewhere. And finally, the fear puts people off from coming back, and there is going to be risk-taking behavior. Look at the opportunities. The opportunities are that there will be new ways of doing things and new experiences. There will be innovations in these difficult times, which we will be able to implement. In fact, I believe telemedicine is reproductive health care friendly because a lot of it is about information, counseling, which can be done very well face-to-face on telemedicine. There is a willingness to reset standards, though they've said temporarily, maybe we'll continue it in future. And today, more than ever, you know, a lot of my patients have been going to online pharmacies for their whatever they need to order. Contraceptives are available on online pharmacies. In fact, they very often get a discount, and this is probably going to be a big way to go in future. Another possible opportunity we have is the government has announced, unfortunately there must be a hiccup at this time, 150,000 wellness clinics. These are opportunities, and along with this there could be wellness helplines which are possible with maybe centralized contact. What will our practice be? Well, our practice will have to be that tell your patient, if she can't come to see you, continue whatever you're using till further notice. They keep calling up and saying, but I haven't followed up for 6 months, for 1 year. Never mind, let your IUD remain, continue with your oral contraceptive, and we will deal with it at some point in time. Innovations that now more than ever I've been using extended COCs, telling my patients to just go on not for just 21 days, but for 42 days and even 63 days. And sitting at home, they see the benefit of not having to menstruate and going for extended COC cycles. Promote IUCDs and LARC, particularly for women post-delivery. In fact, the private sector has just not taken the postpartum IUD. This is the opportunity. When you don't want your patients to keep coming out and you want to protect your patients from risks, let's look at postpartum IUD with a new vision and new lenses. Then, of course, we've got emergency contraception, which has to be made available at the drop of a hat, and we're getting a lot of calls for that. And ligation must be considered an essential procedure. And as soon as operation theaters start, if women need a ligation, that's something they must be given. Coming to the practice of safe abortion. Here the threats are a lot of women are petrified of continuing a pregnancy in the background of the pandemic. So first of all, they need to be reassured and told that if this is a wanted pregnancy, we can definitely help them look after it. And whatever the current evidences tells us that the pregnancy is going to be relatively safe, their risk is the same as anyone else's. Unfortunately, in certain areas, there have been shutdowns, there have been availability of supplies which are disrupted, and this has happened to many NGO clinics, which are working in the so-called lockdown areas or the so-called areas where you've had to have containment, where services have had to stop. Hospitals have refused elective procedures, and some of them have actually considered MTPs elective procedures, which is not true at all. You know, MTPs cannot wait just as deliveries cannot wait. Many of them are insisting on pre-procedure COVID testing, and sometimes we have to bend, but this is really not indicated or necessary. And there is a bit of a clash between the protocol of the hospital and what the authorities are recommending. But there are opportunities. The opportunities are, there is a new way of doing things and there are new experiences. Ratan Tata said that these are the times for innovation which will lead to upliftment, and we need to do that in the medical field as well. Telemedicine, again, we need to look at its application here. And I can tell you that as far as the medical abortions are concerned, what we always have been doing, and more so now, is before a patient comes to the clinic, she comes with a workup and her investigations. She needs just one visit. In that visit, she has an examination, an ultrasound, the medication given, the protocol explained, the form C signed, and she goes back and carries out the procedure back home. This is even more important given the current situation and environment. We have to reset standards temporarily. I spoke about the wellness clinics, and I believe that's a great place for medication abortion, since we know that 81% of abortions in this country are medication abortions and 75% are going to be outside centers. And again here, and I know I go on saying this again and again, you know, during this epidemic, during this pandemic, I've been speaking to friends in public hospitals, and there are a lot of volunteer doctors. And you know who these volunteer doctors are? They are the Ayush doctors. These are not quacks. They are doctors helping us with this epidemic. And if they can help us with this pandemic, they can help us with reproductive health and abortions going ahead in future. Practice, we have to encourage early decisions. Pre-procedure, counseling can be virtual, investigation can be virtual, preparation can be virtual. Medication abortions, I said how it can be a single sitting procedure. She doesn't need to come back. You tell her what and how she can diagnose completion. Manual vacuum aspiration, more patients today are opting for surgical because they don't want to come out repeatedly, and because they are also coming late. In manual vacuum aspiration, simplify it. Paracervical block is simple and highly effective. We have shown it. It is proven. And even if you're using anesthesia, for the sake of your anesthetist, prefer a total intravenous anesthesia rather than putting a tube or a laryngeal mask into the patient's throat. Second trimester, mifepristone priming, misoprostol follow-up, again an extremely safe procedure. It cannot wait. It is time-bound and essential. And recently, of course, we went back to doing something we hadn't done for a long time. Our colleagues in the south of India continue to use catheters, either previous to cesareans. She had an IUFT at 24 weeks. She didn't want to go in for a repeat surgery. We went back to putting in a catheter, and we had a very safe abortion. So this has changed how we are going to practice reproductive health. Finally, I just touch upon adolescent health, because this is not something we do in our practice, but something that's extremely important when it comes to public health. With adolescent health, the threats are that the access is the most vulnerable. And when access is affected, it is the vulnerable young people, unmarried women who are affected more than anyone else. We have the largest population of adolescents in the world. And as it is, we are struggling with laws such as the MTP Act and the POCSO Act. And we really need to use these times of crisis and see how can we simplify lives for our young people. Opportunities. I believe telemedicine is made for young people because they are so savvy with modern technology. I believe this will give reproductive health to young people very easily, and it's even easier for us not sitting across the table and being judgmental. There should be willingness to reset our standards. Our adolescent-friendly clinics and services could go for virtual counseling, could go for virtual advice. We could have adolescent contact centers where a team of people could be listening to what adolescents say and reassure them. And finally, we did something very interesting recently with one of the companies when it came to endometriosis, where you have a bot, which is kind of responding, giving fixed responses to questions to speech. And it's a kind of a learning bot. And maybe something like this can also be used for adolescent health. Social marketing is very important. And for young people who can't walk into a pharmacy and ask for condoms and oral contraception, online pharmacies could be the answer. So finally, I'd like to end by quoting Atul Gawande, who I saw 2 days ago on Indian television with Rajdeep Sardesai. And Atul Gawande said the new norm is to learn from each other, and the learning has to be at hyper speed. He said that we have just months to find therapies and vaccines. And I tell you, friends, that we have to learn very, very quickly how to deal with this particular pandemic in our day-to-day practice. We have to learn, we have to share, we have to face up to reality. We have to develop blueprints and protocols. Sanjeev Puri, the ITC head, today on television said the longer we take to adjust to the new normal will be more stressful the situation in the long run. 4 months on, and this pandemic seems like an extended bad dream. But in reality, it is a challenge to be accepted, to be faced, to be learnt from, to be taken advantage of, and to be finally overcome. And that, I believe we will do. We will finally overcome it. Thank you, Niranjan.
Thank you, Dr. Nozer. It was wonderful to have you. Wow, what a way you have presented and given the whole insight about how to manage. It is amazing to hear from you, and thank you for coming to us. I can go hearing on and on and on, and that's the beauty of this TOG webinar, that we get to hear stalwarts across this country again and again. Now I call upon Dr. Rishikesh Pai.
One minute, Niranjan, I just want to, 1 minute. Just go on, continue. It will take me 1 minute to just.
Yes. I think Dr.
issue
has
there.
given a wonderful insight about how to go about to treat these patients, about post-lockdown and the issues regarding contraception, regarding abortion. And we will be hearing from Dr. Rishikesh Pai. Anybody would like to comment in the meantime, Dr. Bhaskar Pal?
Yeah, I think I just want to add a few experiences to what Nozer said. I practice with a group of hospitals where our biggest challenge is to discipline our patients into appointments. Because we have a chairman who believes that illness doesn't happen by giving prior notice. So you should always have the facility of walk-ins. And that is where we have an added problem, that how do we change that culture to coming in only by appointments. And as Nozer said, we have all been encouraged, and most of us have been doing for the past 6 weeks the online consultations. And what the online consultation helps is that it can minimize the visits. Most of our follow-ups, we can solve the problem, giving them our prescriptions. Of the new patients, we can do one of the two things. Some patients we can identify, yes, you need to come to the hospital, please come in this week. And obviously the patient won't be charged the second time when the patient comes in. And the second group is that we can advise them all investigations, do everything, and then come in so that we can solve the entire problem in one visit. We have to get used to the new normal, and teleconsultation is going to play a huge role in this. I think there is one more challenge that Nozer hasn't spoken about, is we understand on one hand that the economic impact of this lockdown has been huge. We are going to have a crisis in the sense that healthcare will become more expensive. Whether you test, whether you use your PPE, or whether you do both, it's going to have an increase in cost which will have to be borne by the patients. On one hand, there is increased cost. On the other hand, there is an issue of a decreased income and decreased earning and people losing jobs. So that's going to be a huge challenge going forward in private healthcare. Thank you.
Thank you, Dr. Bhaskar.
Niranjan, can I make a couple of points?
Yeah. Yes, Dr. Basab, and then we will go to the gold mine of information, Dr. Rishikesh Pai.
Yeah, just a couple of points, Niranjan. One is about what Dr. Nozer had already mentioned. I think a lot of small hospitals and clinics would need hand-holding for the SOPs, which Nozer did mention about. Because the SOPs which will be COVID-friendly will not come naturally to everybody. And those are things which will be developing over time. The other thing which was mentioned, digital health revolution is here to stay. We will be seeing more of the digital health coming into the picture. And the other thing which Dr. Bhaskar Pal mentioned, that health insurance, which is pathetically low in our country, just 20% of our population is insured for health, is bound to rise. And we will be seeing more health insurance in time to come.
Thank you, Dr. Basab. Now we go to Dr. Rishikesh, the gold mine of information. Dr. Rishi, are you ready?
Yeah. So, sorry about that. A little bit of, getting to know the digital space So I'm very happy. Dr. Nozer Sheria has given a wonderful talk. Dr. Basab, Dr. Bhaskar, Dr. Karki from Nepal. Then we have Dr. Laila, Dr. Leela Vyas, Dr. Nirja Batla. After a long time, I'm seeing Dr. Nirja, and hi, Dr. Rekha Korean. I would like to now go on to the talk. Basically, it's more of a hardcore ART talk, but probably a lot of things have been covered by Nozer. So if you see that, what are we looking at? We are looking at a 2 or 3 year problem. And even I am a fan of Dr. Atul Gawande like Nozer is. And about 4 days back, I was listening to Rajdeep interviewing him. He's a leading surgeon and professor from Harvard. Now he has left, and he said that lockdown is working, but we are not ready to restart. And the Indian curve is flattening. We have about 5,000 cases a day, but it's still not flattened. And we don't know what is going to work. And, but what one point he said is that very important point is that death is not good for the economy. So the lockdown was necessary, because had we not done the lockdown, there would have been too many cases, and then the death rate being 1% or 3.5% in India, that would escalate a lot, and we were not ready. So the lockdown allowed us to gear up for the infrastructure. Unfortunately, India spent only 1% on it on healthcare and that infrastructure. So now I hope that after the lockdown and after this COVID is over, we will start spending 5% on health rather than spending 1% on health. We realize the importance of spending on health. So what are the rules of the lockdown? Here are some rules, and the rules are that you must wash your hand 10 times a day, because if you wear gloves, it's not good enough. You have a false sense of security and you start infecting everyone. So better not have gloves, but wash your hand. But in India, there is a problem of water. So it's very social distancing of 6 feet is very important. Mask is very important. And if you are a general citizen of the country, a 2-layer mask made up of 2 different materials, preferably cotton and silk, is the ideal mask. And screening is very important. Triage, temperature and testing. And ultimately, if you are a unit, your family is like a unit. If you fall sick, all the family should stay at home, because you are cohabiting in one house. So you have to have social responsibility. So as far as Dr. Pai, that's my take, is concerned, we need to do responsible behavior, and it's very important, because otherwise you will kill others. If you don't do responsible behavior, you are going to kill others. Foxy, our organization, needs to have a mass education program, because education is very important. You should enjoy your life in real time. There should be, again, if you look at doctors, we should go for a long-term financial planning. For the last 2 months, I am all the time trying how to give my patient. So pay cuts of your staff, layoffs. You have to handle your workforce in a very humane fashion. Consolidate your practice. As Bhaskar said, we are going to have a dual problem of excess expenditure and decrease income of the patient. Conservation of resources and saving. You must conserve your resources. Don't compromise on your marketing and technological upgrades. You must keep on upgrading yourself. Go back to school and relearn and retrain yourself. And you need to create new business streams. The doctors are all very intelligent, and we can create newer streams of business, not necessarily totally different, but allied streams. Now, coming to the COVID and ART, there was no evidence of viremia as well. After a lot of these patients have died, and a lot of information came from an Italian gynecologist, and he made a very pertinent point. He said there is no viremia in the blood, and hence there is no evidence of presence in the uterus, ovaries, testes, or semen. You may have. There are certain papers now where they show positivity in the semen, but overall there is no trace. COVID-19 is not present in follicular fluid or seminal plasma as a rule, even in non-infected patients, and is not associated with gametes and embryos. However, recently there has been shown that in the epiblast cells of blastocysts, there are some receptors that have been shown to be ACE receptors, and there is no evidence of transmission to the fetus in the first trimester. Probably there is no teratogenicity, but that will come to know now, because the patient that conceived in this 3 months, and when they deliver 9 months later, we will come to know what is, like how Zika virus had a microcephaly effect. Does the COVID virus cross? But there's very low probability of perinatal transmission, placental crossing, or breast milk transmission. So the overall mantra of prevention is that, this virus survives 3 hours in air as droplets, 4 hours on copper, 24 hours on cardboard, 72 hours on metal, And it's very important to do social distancing. As I told you, the 5 principles of staying at home when you're sick: distancing, hand hygiene, face mask, and hygiene and respiratory hygiene are very important. Cleaning of surfaces, normally 70% alcohol is very important. If you have a vendor, he's selling you 40% alcohol and you clean it, gives you a false sense of security. UV light for 30 minutes, or a bleaching solution of 0.5% hypochlorite or a 0.5% hydrogen peroxide or a soap and water solution will kill the virus. And if you are infected or you have a potential, between 14 to 28 quarantine is very important. Now, this is a very important, it's a very happening slide, but this is very important to understand. So what is the PPE? So private personal protection equipment, there is normally, you have the surgical mask, you have the glass of face shield, you have nitrile gloves. These are not latex gloves, these are nitrile gloves. This is made up of artificial material and it is more resistant to penetration than our standard latex gloves. That's why if you wear latex gloves, especially if there's a COVID potentially positive patient, you need to wear a double glove. You understand, sometimes in the ICUs I've seen in China and all, they wear triple gloves of latex. Then you must have the plastic apron, and which is like our HIV apron, you can have an equivalent. And then you have the coverall. Coverall is a water resistant apron, and normally it has got GSM, 60 GSM, 90 GSM, 120 GSM. As the GSM rises, it becomes more thick and less penetrative, but more the GSM, more difficult to wear it for a long time. So you need to have a balance in the GSM. Okay, so now if you have an OPD procedure, as Nozer had said, an infrared thermometer, a hand sanitizer, a pulse oximeter, because sometimes the temperature comes later. If you have a pulse oximeter and they are quite economical, cost about 3,000-4,000 rupees, you put it on your finger, you will be able to make out that oxygen is less or not. If there is a less than 95%, you can pick up before the temperature manifests itself. And so you need appropriate physical screening in the OPD. So if you are in an OPD, you need to just wear a surgical mask, a glass face shield, and maybe a nitrile gloves. But gloves gives you a false sense of security, so you must be careful about it. If you are doing a clinical examination or a blood collection, or you are doing ultrasound, or you are doing IUI, or you are doing embryo transfer, these are recommendations by the British Fertility Society, so I am quoting them. You can wear a surgical mask, a glass or a face shield, nitrile gloves or latex double gloves, and a plastic apron, or you can wear a disposable. This apron is optional, and in my, I have written at the bottom of the slide that N95, if you have access, you can wear it at every level. However, you don't need to, you can wear a surgical mask. If there's a short pickup, you have a pickup which has got 5-10 follicles, you'll be able to finish the ovum pickup in 5-10 minutes. Or you can do it under conscious sedation, and where there is no aerosol generating procedure. It is known as AGP. If there is no aerosol generating procedure, then you can wear a surgical mask, a glass or face shield, a nitrile glove or latex, or you can do double glove latex, and you can wear a simple disposable gown. So it is the same as doing an ultrasound or IU exam. Only if there is a lot of follicles, this patient is going to take a lot of time, there is a chance that this patient may be positive, etc., etc., then of course you need to wear a coverall. So coverall has to be worn only in cases where everything else is difficult. If you are an andrologist or an embryologist, just a simple surgical mask with a glass face shield and gloves are good enough. You don't need to wear anything. So these are important. Where to wear what PPE. Otherwise, you will end up wearing PPE everywhere and the cost of operation will go up. If you see that the shutdown was done for in IVF, and more or less all over the world, people said you shut down IVF because we don't know and we need to conserve the resources for other COVID patients. Healthcare resources were to be conserved. So last 2 months we all shut down. But later on, the shutdown has now been, we can't shut down life continuously, endlessly. You have to restart your economy. So there's livelihood and life. These are the two tussles which we have. Should we start our economy? Will it cause a lot of deaths? Will it have a problem? These are questions which are difficult to answer. So the ASHRI came out with the guideline on 23rd April, and the British Fertility Society, in association with the Association of Reproductive and Clinical Scientists, came out with the guideline on 6th of May. And this is a combination which I'm presenting you of me, my thought process and these guidelines. So these are the 6 points which they said that the guideline should be under. So the first and important point was discussion and agreement and consent to start treatment. So of course, if there are high risk patients, we must explain to them and we should avoid taking them, especially those with comorbidities. All patients should be offered to a choice to proceed with or postpone treatment. Documentation is very important, and prioritization of patients, fertility preservation patients, patients with low ovarian reserve, advanced age, those facing extraoperative pelvic surgery. These are for patients to be prioritized. But overall, you can, once you start, you can take all patients, including donor patients. There is no differentiation that has been made between the normal patients and donor patients. Patients must be comprehensively informed, clearly understand the risk related to COVID-19 disease and acknowledge the increased risk in case of infection during pregnancy. We don't know. We'll have to tell them we don't think there is a history of teratogenicity. We don't think there is a transplacental transmission, but we don't know. We are not very sure. So there has to be an informed consent, and then patient should sign the code of conduct. So very important. This is a very important side that there are 2 tests that are available for diagnosis. One is the RT-PCR test, which diagnoses the antigen. So you take a nasopharyngeal and oral swab together. And sometimes nowadays people are recommending saliva as well. And within 8 hours, you get the diagnosis. Of course, it is not very accurate test, but better than the antibody test, which is a blood test. And it gives you a report between 15 to 45 minutes of IgM and IgG level. Ideally, if you have both the tests at your disposal, then actually you can classify the patients or the healthcare workers into 3 different groups. One is called the native group. Native means both the tests are negative. The second is the infective group. RT-PCR is positive and IgM is positive. And the third is the IgG group, where the RT-PCR is negative and IgG is positive. The IgG group is the best group because suppose I have to identify healthcare workers and I have to form a team. If I do testing on all my healthcare workers, the ones who have got IgG in their blood, I know that they have already been exposed to a subclinical infection and they will be the best to start work with because they will not get the infection, hopefully not get the infection again. So these tests are useful not only for the patient but for the doctor. And just now I was on a television show and I told them that if you want to get the economy back, you must allow testing. You must allow testing of the hotel workers. You must allow testing of the mall because we can identify the people who are not positive and start your business with those workers. But I don't know how the government will react to that test because at present we have got a paucity of tests. Ultimately, 4 or 5 months down the line, when things start settling down, then of course tests will be easily available. Things will change and we'll aggressively have to test. This is the only way of doing this. Then there's a triage questionnaire, which is a beautiful questionnaire. I can give it to all of you. This is by Ashri and I have added 3 more points to it. Have you downloaded the Arogya Setu app? Are you staying in which zone and are you staying in a containment area? So these are 3 additional points which we have added. Our groups have started all our IVF centers and these are the triage questions which we ask them. And after you ask this triage question, you classify the patient into 3 groups which I will tell you about. So you also need to do patient education. I feel that education is a big problem in our country. Our country is illiterate. You talk to them on the TV, it is not. How many people have got TV in their Jhopad Patti? How are they going to access? We have to have some means of educating the mass. Unless the mass is educated in India, we cannot change their practice. So coming to our internal group, suppose I'm talking about the IVF center, we should educate our patients as well as we have to educate our staff. So tutorials on the use of personal protective equipment, advice on continuation of social distancing, information about symptoms of COVID-19 infection, and agreements that treatment can be discontinued. This is very important. Treatment can be discontinued if the patient encounters a high-risk situation. So adaptation of the center is very important. Redesigning of the waiting rooms and working spaces to guarantee appropriate social distancing and ventilation is very important. And you have to, this is very important, subdivision of staff into mini team. Because what happens, suppose the whole staff is working. One day is infected, everyone will get quarantined. So it is advised that you need to create. So we have created mini teams amongst ourselves. As Noza said, telemedicine, management of appointments, limitation of number of visits, PPE and sanitation device for staff and patients, routine sanitation of all areas. I told you about 1% breach is very good to sanitize everything. And follow-up of patient, this is very important, 3 weeks after the oocyte retrieval or embryo transfer to identify potential COVID-19 positive patients and implement contact tracing and sanitation. It's very important to not only finish the procedure, but follow up the procedure. Again, you have to look at the staff, subdivision of staff into mini teams, as I told you, adjusting of work shifts, COVID-19 standard operating procedures, specific training for COVID-19 and emergency agreement. So this is, suppose we have a team of 2, we are created in our IVF center, both teams come positive. What will you do? So you must have an emergency agreement between 2 ART centers. We should not compete with each other. We have to, in this times of COVID, you have to have more and more connection with each other. So if you look at the guidance of H3, the triage, as I told you, the triage questionnaire has to be asked, and you have to divide them into 3 scenarios, 1, 2, and 3. Scenario 1 is that triage questionnaire is negative, patients and partners are asymptomatic. You can include the patient in treatment. Scenario 2 is when in the questionnaire there are mild or non-specific symptoms and triage may be potentially positive. These are the patients you subject to testing. Now remember, if you have testing available, for example, in our Delhi units, we have no problem. The testing is available in all my Fortis group. So we are testing all our patients as well as our staff. But if you have paucity, you have difficulty in accessing testing, the triage questionnaire will help you to selectively test so that you conserve the testing. So based on the test, if it comes positive, you exclude the patients. If it comes negative, she comes under scenario 2 and you can include the patient in your treatment. So this is the flow chart of the triage and the testing and which patients to exclude and include. Coming to the stimulation protocols, there should be minimum exposure for both staff and patients. Isolation of staff, if the staff, suppose there's a ward boy, he started having fever, he has to be isolated. Use of PPE by staff, minimal number of visits, and optimized number of blood tests. Home self-administered. Medicine can be self-administered. And this is very important point. I was attending this lecture by my colleague from New York, and he said that they have assured the patient a medicine refund. Suppose halfway down the cycle, patient develops a symptom. If you tell her that I will refund the medicine to you, don't worry, but you must disclose the symptom, she will disclose it. Otherwise, what will happen is she will fear that, oh, if I don't disclose this symptom, my cycle will get cancelled and I'll lose a lot of money. So they are assuring that the medicine will be refunded if the cycle is cancelled halfway. You can tell them that you can give them at cost price. Vaginal probe and tissue hygiene is very important. Re-triage and action depending on pre-triage results is very important. And you should at all costs avoid hyperstimulation, which should GNRH trigger, and freeze all in patients which are got a lot of. What about the operating room? Operating room where the pickup is being done, negative pressure system should be there. PP is a must, as I told you already in the PP discussion. Minimize personnel. See that very less personnel are there. Remember, the potential infection can be from the anesthetist, from your ward boy, your sister, your embryologist, the patient, and a andrologist. So you have to. They all are very important to this thing. Then when you have to, then the oocyte retrieval need to be performed under local or short anesthesia. I told you that already, that we should have perform it under local or short general anesthesia, and I have already talked about. So these are two very important in the laboratory. Standard infection control procedures and good laboratory practices are important in IVF. However, you don't have to go away. You should have a standard. Routine good laboratory practice principles should be followed, and lab staff should wear masks and gloves. Nothing. They don't have to wear a gown. Minimal viral load using air handling unit. Specialized HEPA filters. High intensity. We have put high intensity UV light in our ducts. And we have titanium photocatalytic converters. These are ones which can destroy bacteria and viruses, and hopefully they'll kill the COVID virus if at all there is a leakage. And the biological safety cabinet. Most of us have class 1 cabinet. So if you have class 2 cabinet would be better, but if there is a class 1, then you should wear the safety glasses during the procedures, but the risk is not that much. And this is the second part. Laboratory staff should aim to minimize handling of pipettes, pens, keyboards, and clean down equipment such as microscope, controls, and eyepiece between operators. So one operator. If there are two, so I have told my staff only one will work in the lab at a time. 2 operators. If at all there are 2 operators, you must keep the distance, reduce exposure of native follicular fluid and sperm by dilution and safe disposal. Multiple dilution steps should be there, etc., etc. So these are, should a patient become suspect of, then you should freeze all the gametes and embryos and postpone the cycle. And the last important point is, as far as the freezing is concerned, precautions should be like you are tackling a HIV infection. So for the time being, for the next 4-5 months, the embryos should be separately frozen, because, and we should freeze them in high intensity closed circuit straws, and preferably in a separate tank. If at all you can do it, it is better. This is the code of conduct of the staff and patients, which you can easily access. And this is the, all staff members and patients will be instructed to avoid unnecessary exposure. Each service will prepare compulsory instructions for staff. Attendance at work will be tied to respecting the sign of code of conduct, and we must restrict social life and interaction. This is very important, and regular signing has to be there. Staff members should sign regularly that they are well and have respected the code, or inform the centers responsible if there is an infringement of the code. So this is what I would like to say, and this is the COVID mantra. You can't connect the dots looking forward. You can only connect them looking backwards. So you have to trust the dots will somehow connect you in your future. You have to trust in something, your gut, destiny, life, karma, and God, whatever. So this is what Steve Jobs said, and this is very important. We don't know in the next 2 years what will happen, but if we adhere to safe practices, we maybe will be able to tide over this crisis. Thank you for a patient hearing.
Thank you, Dr.
Niranjan, can I come in, please?
Can I thank Dr. Rishi?
Yes, you can, but at the same time, I want to thank you first. For those of you who do not know, Dr. Kamal Chauhan's father is seriously unwell, and that's why she couldn't join. And Niranjan, despite his father-in-law being unwell, decided like Raj Kapoor that the show must go on. So Niranjan, we really appreciate your sincerity for being here. And I just wanted to put that on record that we're really thankful that you're doing such a wonderful job.
Thank you. I hope you will.
And we hope Kamal's father recovers quickly.
Dr. Rishi, it was a good, important messages which you have given, especially of 24th April of ASHRAE guidelines, and how to see a patient in a triage area, how to go about regarding the ovulation induction, and all the facilities. Yesterday I was talking with you, and you said that now I have divided, 4 to 5 junior residents who are going to now manage the OPD, then examine the patient, and then get them ready for embryo transfer. So I think you have already started, and that is the message which we have to give to all the ART clinics. And we are not here to compete with each other, but to be friendly with each other and try to understand that this period is going to go for a long time. And it's really nice that you have highlighted. Even Dr. Nozer, I would like to thank you for a wonderful insight. Now, we have also cyclone which is being there in the east, and I would like to welcome, still there are viewers who have crossed more than 2,400, and this above message is in Bengali. I'll try my best to say, Shoboy ke welcome korche for my doctor friends from East and Bangladesh. Please welcome all of you, and please join us. Thank you so much. The next speaker will be Dr. Rekha. I would request her to please put on her mic and please go ahead to say about endoscopy. Endoscopy, we have got guidelines of IAG, we have got guidelines of ISG, we have got European guidelines. And I would also like to welcome Dr. Karki. He has come from Nepal, Virat Nagar, and he is the dean, the chairman, the faculty head. Sir, you are always there with us. You are our neighboring country. So I go back again to Dr. Rekha. Madam, we are all eager to listen from you. Please go ahead. Thank you so much.
Yeah. Good evening to everybody. And thank you, Niranjan, for organizing such a nice show. And also, I would like to wish your father-in-law a speedy recovery. And to all the people in the east from Kolkata, I hope everybody is safe there. We are all worried looking at the TV. So my topic is about laparoscopy. And the return of the laparoscopist can be as scary as the return of the mummy. But we know that COVID-19 is going to stay with us for 3 to 6 months, if not longer. At some point, we really need to get back to helping our needy patients. And we need to decide how can we break free from the fears holding us back as well as our patients back. Patients have to be offered the best treatments available to them to manage a particular condition while maintaining the risks, while reducing the risks to the medical team and to the patient and family. As always, medical management should be the first choice where feasible, and when it fails, we need to offer them a surgical line which includes laparoscopy. The first choice for attempting laparoscopy would be in an emergency life-saving procedures like an ectopic pregnancy or, for example, torsion of the ovary where her reproductive life is taken care of. When medical and conservative management fails, then we go into laparoscopy. Ideally, there should be a COVID antigen test being negative. If negative, we can take her up for laparoscopy. And if COVID status is unknown and it's an emergency, then we should use all universal precautions by the whole medical and the supporting team, which is very important. If COVID positive, we have now been asked not to refer the patients to the government hospitals as they are already running full. So even such patients we've got to manage. We should proceed with open surgery or laparoscopy as is thought fit at that particular moment. If patient is on medical management and her COVID reports, that is medical management for ectopic say, then her COVID reports come as positive, then continuing medical management is not possible as she will have to be closely monitored during the next 1 week daily by 3 sets of medical teams, including your nursing and cleaning staff. This would mean exposing a large number of your team to a COVID positive patient, even if they are in PPE. Moreover, if she ruptures, then going for an emergency laparoscopy, there is less, or laparotomy, there is less time to get the team into PPEs and start operating, organize blood, etc. So we need to think that perhaps if she is positive, then you're probably better off going for laparoscopy. And performing elective surgery would be the next step. So some things like was alluded to by Dr. Nozer is whether laparoscopic sterilization can be done. We should discharge all patients after delivery, whether cesarean or normal delivery. Some sort of contraception should be advised to them so that they can go ahead with that. And if not, we may have to do sterilization. Now, elective surgery, we need to subdivide here again as semi-emergency. For example, a procedure like pain relief in severe dysmenorrhea due to adenomyosis or chocolate cyst. Sometimes we may have to take up the patient because she's repeatedly coming to the clinic over the past, say, couple of months, and we need to help her out. Say chocolate cyst. These women need laparoscopic surgery to give them best results and an early recovery, which is very important for them. In such cases, protecting the team becomes very paramount. For intractable menorrhagia, not responding to medical management, then some will prefer definitive surgery for menorrhagia, but a combined decision needs to be taken after adequate non-directive counseling for laparoscopic or conventional surgery. So you need to give her the choice. These are the problems which can be there. This is early recovery or whatever. Non-directive counseling should be there. Here we have to protect the team during the surgery and after. So in the initial phase, we need to choose patients without medical comorbidities. Consent form which says that they have come on their own accord for such treatment is very important. There is also evidence that surgery in an asymptomatic but infected patient is associated with more severe disease of COVID and a mortality rate of 20%. This possibility should be explained to the untested patient and consent taken accordingly. Anesthetic precautions, as we know, GA is the biggest problem in laparoscopy, especially GA. During intubation and extubation is very important. And there are lots of methods which we have come across, how to have a hood across the patient, etc. And these you must organize in your theatre before you can actually start. what are the portions of the intubation set that are to be discarded with each case, etc., is very important. And at least an hour gap is required between surgeries for deep cleaning, half an hour for cleaning, and half an hour for sterilization. Anesthetic trolley, operation trolley, and the laparoscopic trolley should all be readied and kept outside and covered. And there is actually not much scientific evidence to say that minimally invasive surgery poses a greater risk than conventional surgery specific to COVID-19. There has been earlier reports of other viruses. For example, when cauterizing the verrucae, that HPV virus was found in the smoke. So this is why we extrapolated to laparoscopy. However, we have to keep that there is this possibility is there. So when sudden desufflation occurs at the end of your procedure through defective valves, or maybe intentionally, or at the end of the procedure, or at time of tissue extraction, we need to be careful for the sake of the staff. One staff and one side port should be used for smoke extraction. The smoke is evacuated, if possible, through a 2-bottle suction device, with the first bottle completely filled with sodium hypochlorite solution, and smoke should bubble through it before being sucked out. Ideally, if possible, Begadine, Megavac from J&J, or you have the Air Seal by ConMed. These could be used, but they are prohibitively expensive, and I don't know many centers who have these. About the incision for the ports, they should not be too large so that gas doesn't escape from the sides of the cannula. So an open method of entry is discouraged, as gas can escape from these gaps between the cannula, and therefore one needs to prefer direct trocar entry or even a varies. Now, electrocautery should be at the lowest settings to prevent charring and smoke formation. During surgery, minimum pneumoperitoneum should be utilized, and least time should be given for Trendelenburg. You need to correct it as early as possible. Remember, before removing the specimen, complete desufflation is done through the designated side channel. Use of intra-abdominal drains are minimized again to avoid any contamination during the wards. Now, facial closure of the 10 mm ports is important, but it has to be done only after desufflation. On the one other important thing is where you have to think that in open surgery, in laparoscopy, there is minimal contact with body fluids and tissue. And there is ability to filter the aerosolized particles through the tube and through the suction apparatus, which cannot be done in conventional surgery. So that is an advantage to laparoscopy, and there is a shorter hospital stay and therefore less footfalls within the hospital. One needs therefore to consider all this in your decision making. Lastly, I would like to say that all OT personnel need to be aware of the risks in both types of surgeries and the important steps to reduce the risks. Only essential minimal staff should be within the theatre at each step. Minimal staff for the anesthetic team and minimal staff for the surgical team. Sufficient quantities of all materials and drugs during the time of surgery so that they are not running out mid-surgery. And there should be no mid-surgery changing of cylinders. So, and the surgical team only enters after the GA intubation is done, and then everything is ready. And similarly, only after only then
Now it's only hour.
Okay. So these are the important things I would, I think I've touched upon, and I was told to limit my talk to 5 minutes. I hope I haven't overshot that. Ranjan?
So thank you, madam. You have given an overview. Basically, now endoscopy has to be a little to be hold back. That's what I feel so, and that's what is, unless it is very essential. The guidelines mention that we should try to limit ourselves for only emergency procedures, to do like a salpingectomy for an ectopic pregnancy or for a twisted ovarian cyst or a torsion. And obviously it's a malignant issue, then we might consider, but we have to have a good setup and a good team. That has to be more important. And I think testing for COVID patient has to be done mandatorily before, if it's an elective procedure, because it's better that we don't give the risk and this infection to our staff and to our the surroundings. So that's very important, and you have done very nicely described it for this. I would like to tell here all of the viewers and panelists that you all are Corona warriors. In spite of cyclone, in spite of Corona, COVID diseases, you still are here holding the fort, and everyone is doing the greatest thing for mankind in this time, for infertility, for abortion, for contraception, for family welfare, for endoscopy. I can just go on and on, but it is wonderful to hear from all of you. Thank you so much, and especially the expert comments which are coming in between. So there is power failure also going in east. So we have our friends who are joining in and coming and going. So please bear with us. Now I go to Delhi, AIMS, Professor Neerja Bhatla, who is in charge of gynae oncology. And recently they opened up a very big center at Jhajjar, and she will give an overview of what she has been doing about the patients there. She told me just few days back that we have got, Niranjan, 500 patients being lined up for malignant cases. And I'm really worried that how far are you going to manage them, especially in this post-lockdown period. So, madam, the mic is yours. The whole nation and East friends from Bangladesh, Nepal are really eager to hear from AIMS. Please go ahead. Thank you so much.
Thank you very much, Niranjan. Thank you for organizing this in all these constraints, and it's such a pleasure to be on a panel with so many luminaries. I think my task has been very much made easier by all the talks that have gone before, because there are really so many basics that are common for every subspecialty, as it were. And yes, you were mentioning about our Jhajjar Center. Our Jhajjar Center actually has presently become a COVID center. So presently we have almost 400 patients who are housed over there. And if I may say so, I think they are lucky COVID patients, because there are excellent facilities, single room isolations, and they're getting the best of care over there. But definitely our cancer work has taken a backseat till now. Now let us look at how it has gone before and how we should go forward. So initially, of course, we were doing only emergency procedures, which could mean patients who came with obstruction, hemorrhage, and usually that type of things in the emergencies, and guiding them. Our chemotherapy was in the first lockdown at a very low ebb. Only old cases were being done. Radiotherapy similarly was very low ebb. And we were also, we have to wonder when we call in patients also that we are increasing traffic on the road, we are increasing communications, we are maybe interfering with those circles of transmission. So we have to be very careful about what is going on. And of course, preventive surgeries, preventive services of cervical cancer prevention, including treatment of CI in detected cases, was completely postponed. But now we have reached a different level in lockdown 4.0, where we have started doing our surgeries as well. So again, the question does come of prioritization. We want to first take those patients where we expect that we are going to have a curative intent with the surgery itself, where we are not dependent on whether the chemotherapy and radiotherapy will be aligned as well. So those may include the well-differentiated endometrial cancers, early-stage ovarian cancers, early-stage cervical cancers, and we have now started posting these cases. But as you mentioned, we are still reluctant to do the MIS, so we are doing right now all the patients with the open method, I have to say. Now comes the question of patients who require adjuvant treatments. So our chemotherapy also now has started working, and they are enrolling new cases since lockdown 3.0. So yes, we can consider them for chemotherapy, but we must remember these are daycare procedures. They require patients to travel. They are patients who are immunosuppressed. So we do have to keep an eye on where the patient lives, what is her affordability, is she going to be able to travel to meet her the appointment dates and do the needful and all that. But yes, now we are ready to take these patients also. So there are several who were getting the new adjuvant chemotherapy, and in the lockdown we carried on and gave more cycles of neoadjuvant chemotherapy, and now that whole list is emerging, which are ready to be taken up for surgery. And when we have patients who are advanced case procedures where maybe only a palliative intent, then we are little reluctant yet to take them. And that is why is that we are doing COVID test on all patients whom we are posting. But we must remember the value of a single COVID test is not 100%. Even if it has come negative, you should be prepared. We have cases in our obstetric, for example, who were not tested because they were not from hotspot areas. And then later that turned out that became a hotspot area, that patient came positive. It happened with one of our GTN patients like that. So our staff was exposed, but because we were being very careful about a sort of universal precaution that we are maintaining, everyone using face shield, everyone being careful about their masks, the patient's masks and all those things, that we were lucky that nobody actually became positive from that exposure, and that is our goal really. So we must be very careful, no matter whether the COVID test is positive or negative. Positive, of course, is a clear story in oncology. We are not. But if there is only a palliative intent to be achieved, then that patient could actually be harboring an infection which may flare up in the post-op. She may acquire an infection somewhere in the process of dealing with so many people. So we don't want to expose them for palliative intent yet, and we are not enrolling these patients for surgery. But as Dr. Rekha rightly said, every procedure takes so much time. It takes so much time to take them in, all the precautions. Our teams are very valuable to us. All our healthcare workers, all the supportive staff who are in prime of youth, highly trained people, we cannot afford to lose a single one of them. We don't want any risks for the patient. We don't want any risks for our healthcare workers or other staff either. So we have to take all the precautions. Precautions take time. The cleaning in between cases takes time. So right now we are not even trying to do more than one elective case a day because there's other work to be done. Moreover, some of our OTs are committed now to suspect care. Some of our wards are committed to suspect care. So the facilities available for routine work are also at this time a little compromised. But I think if we follow this guidance, in summary, that we must test everybody, yes, but we must be very vigilant. And as Dr. Rishikesh said, encourage patients to give you the accurate picture and be vigilant to look at them also and see how it is. Does she look like she might be harboring anything? Does she look like any concerns are there? Post them carefully and be very careful during the surgery to be extra meticulous. You don't want to be going in for anything that you could have prevented to reopen a patient in these times. So be extra cautious and be very careful with the follow-up plans also. Let them know upfront what is the level of their commitment and how often they will be expected to come, and let them be with you, because no point doing a very good surgery if they are not able to comply with the adjuvant treatment later.
Thank you, Dr. Neerja. It was such a wonderful talk of yours. You explained so nicely. Try to be masterly inactive. That's what you meant to say, especially in lockdown period. And please go ahead. You can go ahead with radiotherapy or chemotherapy. But there are certain malignant.
We are doing all the radiotherapy and chemotherapy, and we're taking up all the endometrial cancers, particularly, who are very much the ones who are going to respond well. So all the patients who have been given some kind of supportive treatment, we are now trying to see that they get the definitive surgery.
Bhaskar, I would appreciate your warriorship. You had a light off. I think there was an issue about cyclone, and still you came on your iPhone. I mean, that's amazing. You can unmute, but that's what we are trying to figure out, that in spite of so many issues, there are 2,700 members who are still logged in and are still eager to see every one of you. And I'm so happy that in spite of so many obstacles, Bhaskar, you are a fighter as usual, what I saw 30 years back. You are going to fight not only COVID, but you are going to fight even the cyclone and the light which is there, not going and coming back. And obviously, Pasap is also will join us very soon. So we have heard from all the stalwarts. Now we go to Dr. Swati. Is she there? Dr. Swati Manerkar. She is going to tell us about how she has managed those 136 babies of COVID which were positive in Sion Hospital, and obviously we delivered them. There was a lot of media attention initially of what went wrong with Sion Hospital and those body bags which were seen. But obviously we came out, and then there was you all who came together for the doctors from all the aspects, and that's what we did, a miracle. In spite of a non-designated COVID hospital, we delivered 136, and every day we are delivering, and we are really managed. Thank to our administration, our dean, and all the municipal corporation help which we have got. And Dr. Swati is a leading lady in the neonatology department, and she has been managing those cases day in and day out, and she has been there with us through the thick and thin, and she will guide us what are the breastfeeding guidelines, because there are many issues like a patient is COVID positive and the baby is negative. Incidentally, the report came as that all those babies which we delivered were not having COVID test being positive. That's what we came to know. So surely, Dr. Swati, can you please unmute your mic? Your mic has to be unmuted so that you can just join us, and we would briefly appreciate 5 minutes from you, how you manage these cases and how you would advise about breastfeeding and your take-home messages. Please join. Welcome, Doctor.
Yes, good evening everyone. Thank you so much for inviting me to join you all here. Well, being in the hotspot of the country, the Mumbai Sion Hospital, which is close to Dharavi, and we've seen a tremendous rise in the number of cases in the last fortnight. And with the ICMR strategy allowing us to test mothers who were asymptomatic, we found lots of mothers testing positive, and that led us to test the babies. So the latest figures in our hospital are we've tested 10 babies positive out of over 125 babies who we tested. All these babies have been asymptomatic for COVID. They do continue to have their neonatal issues like jaundice or feeding trouble, etc. But no symptoms which can be attributed to the virus. We have very, very strongly encouraged breastfeeding. So all of them are breastfeeding. All of them are thriving well. We've also tested babies who came to the NICU and who were delivered by these COVID positive mothers. So far, thankfully, none of the NICU babies have tested positive. So the NICU is going on the way it would go on for a COVID or a non-COVID mother. But I think it's very, very important that we just drive away this fear that keeping the baby and mother together might cause an infection in the baby and could cause adverse outcomes. I think breastfeeding is extremely vital because it is going to protect the baby not only against the COVID, but also against all other preventable diseases which contribute to neonatal morbidity and mortality. So that broad picture needs to be kept in mind. So far, transmission through breast milk is not definitely proven. Transmission vertically is not definitely proven. So the only means of transmitting remain horizontal. So respiratory hygiene, good hand hygiene is very, very crucial. What do we expect in the times to come? Well, I really don't have answers for that because we are all on the learning curve. We have babies who are well at the moment. About 50% of them have tested negative despite not getting any drugs, because so far no drugs are recommended for treatment of neonates. But I think it's just the breast milk which has worked wonders for them, or there's some antibody which is passing across in the milk and the babies are doing well. But we really don't know what to expect as they move from the neonatal to the paraneonatal period and infancy. Just keeping fingers crossed that we can keep it all under control and hoping not to see too many major complications in small babies or small infants. So my message is please ensure that mothers and babies are kept together, and we do advocate breastfeeding very, very strongly.
Thank you, Dr. Swati. You gave a wonderful insight, and the way you are dealing day in and day out, apart from obviously our medical department, our surgery, our ortho, our pediatric department, our paramedical nurses, ward boys, servants, and the most important thing, our frontline junior and senior residents are amazingly doing, and we would like to share that not even a single resident is positive. That is very heartening, and really we are taking all precautions. And thank you to Dr. Jayashree Monkar madam, who was our former dean, and she is heading our department, and obviously she is being there. You are representing our department, a wonderful job which you are doing. What a show this has been. Challenges of tech to people to environment. In spite, we all have connected across segments and places to gain more and more knowledge every day. Hoping this too shall pass. Thanks, Dr. Swati, for that wonderful message. We will join with you back soon. Please don't go away. Dr. Leela Vyas, I would like you to unmute your mic and share the Jaipur experience. We have been hearing from you, from your side, that Jaipur is doing very good. Thank you so much. Please unmute your mic and please join us. Thank you. Yes, we can hear you.
Niranjan, for in this webinar, where all the stalwarts are there. And definitely Jaipur, as Dr. Swati, that Bombay again a hot zone. The Jaipur is next to Bombay, and all problems thus, as we said in lockdown 4, it has become increased. I think we have to work more safely in this time, because previously there was the lesser number, the patients, less of the patients were coming, and all our previous speakers, they said that we have to go with the telemedicine and then to educate our patients how to behave that and how to come that. They are calling us, we are just explaining everything and giving all advice on telephones and telling them that you stay at home, but still they want to come and visit the doctors, because it is a long time practice only. They think that until unless we show to our doctors, because it is our guidelines which we have initially followed, that in 6 months of pregnancy, definitely you come and show. 4th month we are doing with us anomaly scan and all. So there is a problem that in sitting in Jaipur, I am facing that from the nearer small villages, they are, because they were residing in Jaipur, and anyhow they have reached to their places, and now they want to consult their doctors. So they are more and more patients are coming from outside. We are just managing them on just on mobiles and on WhatsApp. Please send her these, and all our colleagues are doing this. But now the problem and challenge is that of asymptomatic patients. Jaipur is doing very good. I will say that whole Rajasthan is doing very good. But the number of cases, yesterday I have talked with Udaipur Medical College HOD. She was telling that as the migration of all these workers, they are coming, then it is that more and more cases are getting, because these migrants, one of the places is one from the Bikaner Medical College. I got this news that some of the patients, those who are coming from Nagaur district, where the so many migrants from the Kuwait, they have come. They have some strains. These patients are very serious. These are I think any of the strain of these viruses must be more virulent, and the ladies are coming to this hospital, getting respiratory distress and dying fast. So 2-3 cases immediately within 2-3 days it happens. So it is again a point of this further research, that which is there any difference into the strain of the viruses, those who are coming from outside. So this the advisory which has been given by Ministry of Health to work in COVID or non-COVID area, that has to be followed very strictly, because by that, if any breach in continuity of any your PPE, or you are working in that treating a patient as a non-COVID and it comes after testing that or after doing procedure, means patient delivered, you have done either you have done cesarean on 2nd or 3rd day, because the most of the patients coming in emergency, you are sending the test, and once you have done their obstetrical management, and after doing this procedure they are coming positive, then definitely these advisory we have to follow, and we have to follow that SOPs for the health workers. Is there any breach in their PPs, or how they have examined that patient? So according to that, they have been divided into the high risk and low risk, because we all know as per the low risk means they have followed their all guidelines by using proper PPs, distancing and everything, and they have done a procedure, either the cesarean or the delivered patient, or the patient any coming for the incomplete abortion, they have done their evacuation, any procedure they have done with the proper use of their PPE, then definitely they come, and the patient comes afterward this procedure, they come to know that she is positive, they come under the low risk. But still, if any cases come positive, whether it is in the private sector or the public sector, the proper authorities to be informed. So they will come and assess your level. If you don't know all these guidelines, then definitely you come and call them, and they will assess you, and then they divide you that whether you come under the high risk zone or high risk case or a low risk exposure. If low risk exposure, the guidelines clear cut say that if you send your test, you come negative, and then you can work from the next day onwards. But if you are a high risk exposure case, definitely you have to send your test, and according to ICMR guidelines, the test to be repeated. You do your self quarantine, monitor yourself for any symptoms and all. So this will decrease if we have knowledge of all these, and now this is the time that we have strictly followed these guidelines, then only we can save us. So now the time is that all my previous speakers, they have said how to triage your patients when they are coming to your clinics or to the hospitals. They should be educated that we will examine your temperature, we'll see your temperature, we'll ask your symptoms, because sometimes the patients say that you just want to avoid us, you don't want to see us, that's why you are asking so many questions. But in this way, so I think how to educate them, whether by the TV or the print media, every time this is giving, but from our side, definitely we should do something to educate our patients. So that's why they all were talking that there should be a system of that pre-appointments. So during taking their appointments, we can inquire these things, because this is very much required. If I'm talking about the Rajasthan, the containment zone, one of the area is there. The survey was done, around 5,000 pregnant ladies are in that area. So you can think of that, what will be there, what outburst will be there, because that zone is of a very high risk zone. All medical colleges that have, in one of the private medical college and one of the government medical college, 2 centers for the COVID has been made for the pregnant patients. Even if patient, 2 days back, one of my junior colleagues called me early in the morning that I did a cesarean at 12:30 and I got a report at 1 o'clock that she is positive. So how to do? So we she informed to the CMHO, and CMHO team has come, and then they have that all the staff, those who come in contact with that patient, because that patient was asymptomatic. The test was sent previous day and was planned. She was a case of previous cesarean, so planned a private elective cesarean on next day. But in the night, she came with a leaking with meconium. So she has been taken as that. She inquired from the private, this test was sent to some private laboratory. So again, the laboratory person has to be trained about that. If any patient comes positive, please inform the center, because they are following this. If within 5 to 6 hours, they are giving a negative report. But if it is delayed, so we should definitely, after this case, we all came to this point that if the report is delayed, definitely it may be positive, because there is some protocol. Any private laboratory, those who are doing these tests, if it comes positive, they have to inform first government, and government will release their all things, and then they can declare the result to the private center. So these are the challenges which we have to take under consideration, and we always ask which of the lab because in Jaipur there are the 3 private labs they are doing. One is the government SMS Medical College is doing. So and government center, it is always load is very high. So the test reports getting late. So everyone is trying to do very safely, but still every 2 or 3 days we are hearing that one of the patients, she came positive after the test, or the lady came because the test has been sent previous day and she came into the labor in midnight. So these are the challenges which we are facing, and the one thing is very good that, as Dr. Swati said, that in the Sion Hospital, no any single resident or any health worker has come positive. But in Rajasthan, we are getting some of the health workers, even our resident doctors, they are coming positive. Those who are doing in their duties and their with COVID patients, repeatedly we are explaining them, all the teachers, they are doing hard work to just sensitize them how to wear their PPEs. And so this has become a very important part on that, the education of these things, because a new house surgeon, they are not very serious at. So in this lockdown 4 time, all the private means hospitals and government hospitals, they have to do. Then again, that Dr. Rekha and Dr. Neja, they were saying how to do this planned surgery definitely in all these. When obstetrics, so many emergencies arises, a topic we have seen, incomplete abortions, then delivery definitely cesarean and all. Then one of the procedure is the tightening, definitely answer class. Sometimes it becomes one of the need for that. So these all precautions are taken by that. And all of centers in Rajasthan, definitely so many areas are there. These are very remote areas. From there they are coming. And in government sector, on PHCs, CHCs and everywhere, the guidelines has been made.
Thank you, madam. Thank you, madam. You have done a wonderful job in Rajasthan. Thank you so much. Now we move on to, we appreciate your talk, Dr. Leela. We have just a more minute for you to finish. We will get back to you soon. I request Dr. Laila Arjuman Banu to please unmute her mic and please come on the scene. We are waiting eagerly what's happening in Bangladesh. Then we will be going to Dr. Karki. You have 5 minutes, madam.
Thank you. Thank you very much. Actually, I'm grateful to Dr. Niranjan for involving me in this very important wave meeting. Is it audible?
Yes.
Can you hear me?
We can hear you.
So Bangladesh, the condition of the Bangladesh is just like India, because our cases are going increasing in number, and also the death rate is going higher. So the great thing we have done with our Gynecology and Obstetrics Society, with the government, we developed a protocol for management of the COVID. You can see this is the guideline book we have already developed, which contains everything about the coronavirus, the antenatal checkup, the pathophysiology, the postnatal, internatal, contraception, infertility, like this. And so the one surprising thing is that in my chamber, I am doing the chamber very restricted by limited, but there are the more numbers of pregnancies.
Madam, if I can interrupt you, is this book dynamic? Does it changes every 6 hoursly, or does it change every 1 weekly? Because here we are changing it dynamically. Because it's a book. Because if we need guidelines which are changing every weekly.
We have already published.
Yes, madam, continue.
We have already published and submitted to the government for final drafting. I think if there is any change, then later on we can change it. But nowadays it has been written in so much way that only the guidelines are given there how to manage the patients.
Madam, what is the status of COVID in your country? What is the status of COVID numbers in your country?
Yeah, still there are, today I can tell you the number. There is a death of 238, the whole country, and there is affected persons are more than 2 lakhs. So this is the condition, and it is going increasing.
So you have 2 lakhs patients.
Actually,
Madam, 2 lakh patients are positive for COVID in Bangladesh. That's what you are. Oh, and how many obstetric patients you are seeing with these issues?
Obstetric patient with corona?
Yes, madam. Yes.
Actually, what I was telling, that we have developed some hospitals in corona hospital, and they were dedicated for the treatment of the corona patient,
Yeah.
some COVID patient, and also with pregnant patient. There are separate OT with separate teams, operating teams, and after every 7 days they're changing the teams. And staying and also the food is supplied from our society. Society also doing we have 13 branches all over the country, and we
Very
have
good.
passed the guidelines to them, and also they have been following the trial system and also the treatment how to manage the cases. That is one.
Excellent.
And the number of so we are actually try to follow the trial system very much, and we are this is the third web meeting today for me, because we are doing so many web meetings, including the contraception. Today there was contraception, psychological changes during the corona care patients, and violence against the women and the children, because Dr. Rishikesh and Dr. Najesh here, they have discussed a very good presentation they have done. But one was missing, that they have not told about the violence. But in our country, the violence is more than previous one, and it is
Oh my
alarming.
God.
So there was
You are facing violence in Bangladesh for doctors? That's
not for doctors, but the women, housewife, and the children, in the middle class or low middle class families. And there were so many statistics we have discussed today, so it is actually alarming. So the action should be taken against these
okay. Do
incidents.
you have a
And we
central law? Do you have a central law preventing violence or taking action against those miscreants who have created violence?
Yeah, we have very good laws, and our government is working very hard on this violence. But nowadays, they are all busy with the COVID patients, with their COVID patients, the normal patients to have to stay at home, but they are not following the rules. Our people, they are roaming in the roads, and they are doing shopping, marketing like this. So as the pollution, this is actually the matter. So some violence is going on, and it is increasing day by day.
Madam, please be safe. All of you be safe. I would like to correct here that the WHO figures for Bangladesh shows 24,000, if I may correct you. And it is not as what you said, 2 lakhs. There are 24,000 cases. Yeah, 24,000 cases. And we have a listener, Dr. Omar Mulan. He is from Mauritius. He sends greetings from Mauritius to all of you, all of the COVID warriors, Dr. Laila, Dr. Karki, and all the Indian panelists who are here, greeting from Mauritius. He has said and written that where we have 332 active cases and 332 recoveries. We have 10 deaths, unfortunately, no active cases for over 3 weeks. And now we are enjoying watching this brilliant TOG webinar. Wish you all the best in the Indian subcontinent, Dr. Omar Mulan, FRCOG. So that's a message which we have got. I would like to share with all of you. Thank you so much, Dr. Laila, for that insight of Bangladesh. We wish that everything comes fine.
Thank you very much. Thanks to all the panelists and all the speakers. Thank you very much.
We will come back to you, all of you, but we are going back to now Dr. Karki. Dr. Karki, I have met him 3 to 4 times. He has been so nice and kind enough to join us together, and we have 2,600 users. Dr. Karki is the Dean and the Chairman of Virat Medical College, and we have met him at least 4 times now in Ahmedabad, and it is a pleasure to hear from you. Please go ahead and explain what is happening in Nepal.
Namaskar, everybody. Dr. Niranjan, thank you for including me in this webinar. First of all, I would like to wish each and every of us and our family, all our lady people, our patient, a safe life. So, in the meantime, I think we have learned a lot of things from COVID also, right? So first of all, what we have learned is a namaskar, self-distancing ourselves. And it's a brilliant to hear you all people. And we have, luckily, we are lucky enough, we have very little to say regarding COVID from Nepal. So far, we are having 427 positive cases. I'm audible. Can you hear me?
Yes, yes, we can hear you. Yes, we can hear you.
So, sir, we have altogether 427. There is only two mortalities so far. One is male and one is female. Female, I think, couple of days back, she died on 8th day after vaginal delivery. Unfortunately, after delivery, she was discharged in normal condition. 8th day, she came with shortness of breath, fever, everything, and almost in emergency, she collapsed and passed out. And yesterday, I think one more male patient was died. So these are the two incidents. The rest, I'm from the eastern part of Nepal. So far, we have very, very little case. So far, till border, we are a neighboring country with India, and we have an open border. So border is now closed. But as soon as we are scared in a sense, as soon as border will open, I think the cases of COVID will go up. So more or less we are prepared for that. Among these 427, 45 has recovered from a corona. This is a good sign, and they have returned home. And we have also what Dr. Laila has shown. We have government and our medical colleges association have already produced a booklet also, like a small booklet regarding how to deal a patient with ANC delivery. Mostly we are focused in obstetric cases. Rest GYNAE, so far we are taking for the deemed necessary patient only. But Dr. Niranjan, I don't know what financial problem we are facing, but in Nepal, and mostly in private setup, like in our medical college and neighboring medical college, really we are facing a lot of financial crisis. There is no support from the government so far. So holding more than 1,000 people in a medical college or a hospital, it's a huge and very difficult task. I don't know how to overcome with this situation. This is the problem, and neither we can out our staff or doctor from the job, nor we can pay them salary in time. I think this is the big problem. Hopefully, you people in India or other part is not having this problem, maybe, but we are facing, I think this is a big challenge. So I think that's all what I want to say. Be safe, take care of yourself, and seeing you people in a webinar, it's a really a privilege for me. Wish you all the best. Thank you. Hello? Dr. Niranjan? Can you hear me?
Dr. Nozer, please take charge.
Hello, Dr. Niranjan?
I think Niranjan's mic is on mute.
Oh,
Yeah,
okay.
yeah, I'm fine. Thank you. Thank you.
Yeah, and the cases in obstetric practice and gynecologic practice in our setup has almost decreased 80%. 80%. Like last month before COVID, we were having around 550 deliveries per month. Now it has gone to less than 200 now, maybe because of current time, this is no transportation. People are now making a lot of home deliveries, and I know it's a miserable time for them also. And the local vendor, they are providing the service, and hopefully everywhere in the world, maybe in India also, the hospital delivery ratio has been decreased. isn't it?
Yeah. Yes. Thank you. Thank you,
Okay, thank
Dr. Karki, for joining with us. And now I would call upon Dr. Bhaskar to share his experience from his Apollo Glen Eagles Hospital. Dr. Bhaskar has been so nice that he has his electricity being not working there because of cyclone, but he is being there with us on iPhone. Dr. Bhaskar, please join us. We would like to share an experience from Kolkata. There are about 100 questions being lined up. 2,600 people are still hearing us. And there's a message from AIMS Bhubaneswar. It is so nice and wonderful to listen and learn from my all brilliant stalwarts, Professor Nirja, Professor Pai, Dr. Nozer, Dr. Rekha, Professor Chavan. Thank you, TOG, and Dr. Niranjan. It was nice to hear. And Doctor from Nepal and Bangladesh too. Warm regards. Dr. Sweta Singh from AIMS Bhubaneswar. It's a state of affair which changes country to country. I find this such a challenge. Thank you so much to be here with us. Dr. Bhaskar, the mic is yours. Please speak.
Hi, Niranjan. Thank you. I hope I'm audible.
Yes, yes.
We have some lessons that we've learned during the course of the past 6 to 7 weeks. Now, in West Bengal, the situation has been slightly different in the sense that while there are COVID hospitals, all private hospitals have been asked to create a isolation ward as well as a COVID ward to some extent. So we originally started with a 14-bedded COVID ward, and what we learned at that point of time, each symptomatic patient was the most dangerous. About 4 weeks back, one of our patients who was in the oncology department admitted for an advanced case of lymphoma, admitted for 3 weeks, and nobody thought of swabbing him till at a point of time when he desaturated, and he was swabbed and it turned out to be positive. Over the next 7 days, what happened is we found that he had managed to, from him, the infection had spread to 5 other patients on the same ward and to 12 healthcare workers in our hospital. Unfortunately, we have to learn to live with COVID, as everybody said, and every hospital in the country will, at time would come when everybody would have COVID patients as well as non-COVID patients. Now, we have all, I think, the essential lessons that we've learned are essentially what Nozer said, what Rishikesh said, what Dr. Leela, Rekha, Nirja, everybody said, that we need change in practices, we need social distancing. Not only we need social distancing with patients, we need social distancing among healthcare workers. We have had situations where from one healthcare worker spread to another healthcare worker in the hospital bus which they used to commute. Number 2 is screening is very, very important, and screening does not necessarily mean a test or a CT test. A screening means taking a proper history, taking the temperature of the patient, and making sure that the history is reasonably correct. I am of the opinion that if we have the facility to test, we should test everybody, and this is primarily because of 2 reasons. As Nirja said, that all tests do have a false negative. So just because we've had a test, we cannot have our guards down. But having said that, it takes an awfully long time to get used to universal precautions, and universal precautions in all circumstances are easier said than done. So if you have a patient who later turns out to be positive, what will happen is you'll have to send a huge number of your healthcare workers on quarantine, which will affect your services and affect your resources, and there will be cross-infection among patients. And if we want to minimize that, then we need to, what we need to do essentially is that we need to try and test everybody if possible. Unfortunately, ICMR guidelines have been going to and fro, and I rather would stick my neck out and said ICMR has been a bigger part of the problem rather than the solution. And while the Ministry of Health has been doing a wonderful job. The third lesson we've learned is that treat everybody in the hospital as a potentially positive patient. So which means you use appropriate PPE for every setting, deliver everybody in isolation if they haven't had a test. The other issue that we've learned is beware of the asymptomatic patients and healthcare workers. We've not had a single transmission to patients or healthcare workers from our COVID patients or from our suspected COVID patients or from our fever OPD. all transmissions to other patients and healthcare workers we've had from asymptomatic patients. And that is where we need to be beware about. Because if we do not follow the practices and if we do not test people, what will happen is at one point of time for 7 days, we had to completely close our oncology service because we had to send everybody on quarantine and close down the building. I think because we have to learn to live with that, we need to make such changes in practice in the hospital as well. Thank you. Hello.
Thank you so much for your insight from Kolkata. We have got many questions which have been lined up. I will just go through it. Can I get the questions here? Just hold on. Dr. Nauzar, there is a question. Dr. Nauzar, can you hear me?
Yeah, I can hear you.
Yeah, thank you. We go back to Dr. Nauzar. What is a good telemedicine app? This is from Shashikant Bawar, Malegaon.
So, well, I haven't been using telemedicine apps myself.
So what do you suggest? A WhatsApp is a better option or a Facebook or something like direct call?
Niranjan, you know that I am not on WhatsApp.
Yeah, I know that.
So I'll tell you how we've been practicing in our clinic.
Yes.
And this is not new. This is what we've always done. One is we tell our patients that though all my associates have WhatsApp, I insist that their communication with the clinic has to happen by email. And I'll explain why. I'm extremely worried about the fact that we get a lot of messages and reports on the move. We have a lot of questions, and I am concerned that we may sometimes not even know all about our patient when we are making recommendations. So by giving my patients the assurance that they can reach out to us by email, one of my associates spends quite a lot of times dealing with the emails. We have records for each and every patient at the clinic. So the advice is documented, and whatever we do is done in a very rational manner. So for me, that's something we always do. In the last few weeks, obviously, there has been a lot of move to telephones. And I think nothing works like direct telecalling. And for example, all our post-delivery patients who would normally have followed up with me after 7 to 10 days of delivery are asked not to come, but all of them get phone calls. All of them get sent whatever exercise charts and recommendations that they would have been expecting. Working very well. And we also have a system. Every patient of mine sees a dietitian, and in this situation, that consulting has become virtual. They are in touch with dietitians in whatever way they prefer. There they'll be using either WhatsApp, emails, they can use the phone. So use whatever works for you. But remember one thing, okay, there is a certain responsibility both ways. We are all talking about telemedicine very lightly. Telemedicine is going to take a lot of time. We are still going to be spending more time looking after our patients now because we have to space our patients well. And don't take on more than you can handle. And again, times change. At the moment, patients maybe, Bhaskar spoke about financials, extremely important. I mean, here we are talking about private sector, we are talking about public sector. Let's face it, the reality is that at the end of the day, this is a profession, and all my professional colleagues also have to charge a fee. At the moment when the COVID crisis is going on, people are happy to pay a fee. But the moment the crisis is over and we go back to business as usual, patients will again expect to sit across the table from a doctor, spend time with the doctor, complete all their questions and answers with the doctor. So I believe we have to fit it in somewhere. We've already been using it in the past. We are using it more efficiently now. Prepare the patient for your visit. Do your follow-ups with that. Do your investigations with that. Reduce the footfalls in your clinic by using it, and also be realistic about the financials. Bhaskar spoke about how it might be a little difficult for patients to manage financials. Remember, doctors are going to have to see fewer patients. We cannot see the same number of patients and have crowded consulting rooms and OPDs. Now, we are going to have to do our math after a month or two, not at this time, this is the wrong time, this is mercenary. But at some point in time, we are going to have to sit, after all, we are professionals, and we are going to have to see our math, and we are going to say, okay, what works? There are costs involved. This is what the income was. This is what it's become, and we're going to have to make adjustments. And I'm talking this about private practitioners and private hospitals, which really at this point in time are going out of their way, are doing a lot of voluntary work, are doing a lot of unpaid work. A lot of private hospitals are doing a lot of direct charity work for the government because they've been asked to do it in the present situation. But this cannot sustain for a very long time. So my suggestion is, I've gotten requests for lots, a lot of companies have offered me different apps. I've refused them. I find that these different systems work very well in my practice. I don't know if the others have experiences with apps.
Dr. Bhaskar, can you come? Thank you, Dr. Nozer. Dr.
Yes.
Bhaskar, can you come and just add what you are doing there?
We've, in the past, we've used telephone and WhatsApp to erratically answer patients' queries. This is for the first time when I went on a formal consultation platform. And this is an app which is developed by Apollo. It's called the Apollo 247. And I have realized that you need a formal consultation app because we're not doing the outpatient. You are not doing it free. You are being paid for it. You need to do justice to it. This is an app, for example, and I'm sure that there are plenty of other apps available. I know of one called Liberate. What happens is there the patient has the option of uploading all their reports, all their previous prescriptions. So you can do a homework, you can do and go through that. And then during your consultation, you talk to the patient, you advise what it happens. And there are two words of caution. Number one is that, as Nozer said, that this actually takes longer than a physical consultation. But then it will essentially even out, because now when I'm doing a physical consultation, after every patient there is some sort of cleaning going on. So essentially my timing slots have been doubled. So essentially we'll get used to this internet consultation also. Our experience is that most patients are very happy with the internet consultation because they are saving money on the transport. They're saving money that they don't have to postpone other work and come and see you. I have patients who are logging in from the office. I have patients who are logging in from home. So I think you need a formal video consultation app, whatever it might be, to take forward on a regular basis the video consultations. Thank you.
Thank you. I think, Nauzar, we have understood there are many apps, but I think more importantly is the connect, which is very important. Dr. Nauzar, I got 2-3 questions regarding abortions. Basically, this is from Dr. Meera Sethi, primary with 16 weeks pregnancy, divorced, seeking for termination of pregnancy. What are the guidelines from doctor's perspective, Dr. Nauzar?
I mean, firstly, there is the legal and then there is the practical clinical guidelines. The legal guideline is this woman is entitled to an abortion. She's got perfect justification for doing it. And I know people are wary about doing second trimester abortions now, and I think we've just got to stop it. If a woman needs a justified second trimester abortion, we should support her in doing it. As far as the guidelines are concerned, well, let's face it, at the moment, the treatment of choice is a medication abortion using mifepristone, 48 hours prior, 200 milligrams, followed by 400 micrograms misoprostol after 48 hours. Every 4 hours, usually in 3 doses or so, she should abort completely. There is a concern that people have voiced about the legality of using this combination in India. Because let's face it, the drug controller has not yet approved this combination for a second trimester termination. Here, let me reassure you that while we do not have this kind of formal recommendation, one is it's very interesting. The pandemic has kind of told us we can do off-label use, but that's not what's applicable here. When the government of India wrote the comprehensive abortion care guidelines last year, the ministry has actually recommended mifepristone, misoprostol for second trimester terminations. So you're perfectly safe to use this, perfectly justified to use this. But I'll also say on an aside, and this is something I'll always learn from the colleagues from the south of India, that using a catheter, a Foley's catheter, and placing it intracervical, extraamniotically is still a wonderful technique. We had forgotten about it. It's something that works beautifully. In fact, if I have a scarred uterus, I would probably prefer that over the mifepristone, misoprostol. You don't need ethacretine lactate. put in the catheter, instill your 150 ml of saline, tie off the catheter. 6 hours later, take 1 ml of prostadine, dilute it to 10 cc's, inject it, remove the catheter after 8 hours. Your induction abortion interval will be between 12 and 16 hours. And the whole pregnancy is also going to come out en masse.
Absolutely, absolutely. That is a wonderful way of delivering and helping her to abort the fetus at 16 weeks. Yes, she is divorced, and you have wonderfully told how to go about and what medications to be given. Sir, one more question. Can a patient terminate pregnancy during this phase of COVID?
Absolutely, absolutely. Firstly, let's get one thing right. It's sad that a lot of women have been waiting for the lockdown to go down. So my personal experience has been that women are coming much later than they used to because they are afraid of coming out of their homes to meet their doctors. So where I used to see a lot of medication abortions around 6 weeks, recently it's been all 7 to 9 weeks, and some of them have even come later and had surgical abortions. So you have to reassure them. You still have to tell them to come as early as possible. You have to make the medication available. You try and wrap up everything in a single visit. In fact, I think this is good practice anytime. It's not just in the COVID pandemic. You can do a follow-up for them, but usually we used to call them in 2 weeks. What I've done recently is, if they've stopped bleeding in reasonable time, I tell them to wait till their next cycle and maybe come in after the next cycle for an evaluation and for whatever else they require. Very often, post-abortion contraception should be given immediately after a medication abortion, and I will usually start them on a combined OC cycle when the bleeding kind of diminishes or almost stops. And if she wants an IUD, in these times, I'll probably wait, let her do 1 or 2 cycles of OCs, and the moment she can start coming and your clinic kind of normalizes, call her in for the IUD and insert the IUD.
Sir, one more question about ligation. Can we do ligation in this period now, especially in this COVID period we were not doing, but post-lockdown, would you advise it?
So as I explained earlier, that study that I quoted said that we have done 500,000 ligations fewer than we would have done otherwise. That's the kind of ligations we've missed out. And whether you like it or not, that is the mainstay of contraception in this country. While we want LARC, we favor LARC, we push LARC, ligations are important. All this time we weren't allowed to do it because hospitals were told not to do elective work. Well, first of all, if she's having a surgical abortion, please do a simultaneous ligation. But now is the time when we start limping back to normalcy of all the elective procedures that need to be taken up. Let's take up these procedures for reproductive health first. Ligations, absolutely. Concerns about general anesthesia. Again, I said this earlier. Rekha gave a beautiful talk. My anesthetists have gone back to using total intravenous anesthesia. We are able to do most of our procedures. Patient continues to wear a mask. Alternatively, they use all kinds of innovative ways to keep the patient's face covered by a shield or by a bubble. And that way you protect your anesthetists. Remember, your anesthetists are a far greater high-risk medical population than we are. Do not put them at risk. But the ligations must happen, whether it's a mini lab, whether it's pure peril, or whether it is a laparoscopic, with all the precautions that were told to us. With ligation, we are not using cautery, which is an advantage. A ligation is a very quick procedure that most of us finish in a matter of minutes. And with ligation, please use a lot of local infiltration, so you minimize whatever anesthesia or sedation you require. And that local anesthesia with minimal anesthesia is the way to go.
Thank you, Dr. Nauzer. I would like to tell the panelists that we have got more than 3,210 viewers now logged in, and there are many questions which are coming. One interesting question is by Dr. Supriya Borale, and I would like to ask this to Dr. Bhaskar Pal. Are you there, Bhaskar? Bhaskar, I think, is a little busy.
I'm there.
Yeah.
I'm there.
Yeah, well. It's a viral infection, so as to other viral infection, does COVID-19 will affect the spermatogenesis?
We don't know. The answer is we do not know.
Yeah. Okay. Dr. Rekha Kurian, what about negative pressure system used in the OT for endoscopic surgery or an IVF OT? This is from Dr. Megha Jain. Dr. Rekha.
Yes, ideally we should have negative pressure, but none of us have negative pressure theatres. A negative pressure theatre means that you should have your air conditioning or your central air conditioning almost to very limited levels, and have a suctioning which actually comes from above the head of the patient and goes out of the operating room. So this is called negative pressure, so that whatever the aerosols that are created are immediately taken out of the room. But I don't think any of us have it. We do not have. So what we do is we don't put on the air conditioning until the GA has been given, and we switch off the air conditioning 20 minutes before extubation is expected. So that is how we practice, but we do not have negative pressure. Ideally, it should be there. Many of the foreign countries have it because they used to use it for cases who have tuberculosis and other such diseases. So they have a dedicated negative pressure theatre, and it's very difficult for us now to establish negative pressure in our theatres.
Thank you so much, Dr. Rekha.
I just want to come in. I think absolutely, I doubt there are very few negative pressure OTs around. We have negative pressure wards and rooms for the COVID patients. But our anesthetists seem to do things differently from Rekha. We have closed down theatres which do not have a frequent air change. We use theatres which have a air change cycle of around 10 to 12 per hour. And what happens is that we make sure that they push in around 15 to 20% fresh air at every air change. So it takes around a period of 15 minutes for your entire OT air change to happen. So what happens is that whenever an general anesthesia is given, the aerosols that are generated, they will be taken out of the OT in around 15 minutes, and same with extubation. So we advise, unless it is an emergency, the surgeon should not enter the OT after 20 minutes after the intubation, and after extubation for 20 minutes, nobody else should enter the OT. So that is the policy that we follow in our hospital.
Okay, thank you, Bhaskar. There's a very long question by Dr. Ashish Kadaria from Nepal. Is there any criteria on definition for the prolonged labor in COVID-19 crisis? Shall we go for active management if it is more than 18 hours in primary gravidas? Dr. Karki, are you listening this question? For a prolonged labor patient who is COVID-19, shall we go for active management if it is more than 18 hours in a primary gravida?
Of course.
18 hours.
It's already 18 hours, so there's no use of waiting anymore.
Okay. So actually this patient was a relative of this doctor, and I think she underwent a cesarean section and in UK. So I think the same scenario will apply in Nepal. Would you add something?
Yes, same scenario. Because so far we have a very little cases, though we are having a strict protocols and for medical colleges and hospitals. So far, I think we have to not to get in panic. We have to act exactly what we were doing in the past, but we should be more sensible and responsible. But I don't think the course should be changed so drastically, right? So, like Dr. Rekha has mentioned, negative OT. I think these are the necessary things. If we have, it's good. Otherwise, I think you have to use what you have in your hands. I don't think that's make a big difference. So my request to everyone whosoever listening, not to get in panic. Corona comes and goes. Only we have to wait and be sensible. That's all.
Thank you. Thank you, Dr. Karki. It was nice of explaining to you. Yes, Dr. Nozar, I can see you.
Yeah.
And Dr. Rekha. After that, I'll go to Dr. Nirja Batla, madam.
Niranjan, first of all, the rules of obstetric practice don't change. And I know 18 hours, but remember, we don't know the latent phase, we don't know the active phase. I'm not going to comment upon that. But good clinical practice has to be followed, partograms have to be followed. But there are some recommendations which have come from the RCOG, and that's regarding the second stage, because that's the time when the staff is going to be at maximum risk, when the patient is pushing and blowing and huffing and puffing. The first thing is, it is very difficult, but people and patients should have their masks on at all times. I've delivered many patients in the last few days, and trust me, it's very difficult for a woman pushing to keep the mask on, but she must. They've said that do not encourage active pushing. Instead, encourage mothers to labor down and push, wait till there is a strong urge. Sometimes there's a tendency to start pushing too early. And what they've recommended is, there were some changes in the recommendations that we go back to the 1 hour second stage for multis, 2 hours if they have an epidural, and a 2 hour second stage for primaries, 3 hours if they have an epidural, which recently they've kind of stretched much more. So they've said, at least for this time, go back to the old recommendations to not make your patients push a lot, puff a lot, huff a lot. It's only when they start feeling that pelvic pressure and when they're almost crowning, that's when you ask them to start pushing.
Can I add?
Yeah, Dr. Rekha, after that I'll go to Nozer and then Dr. Nirja Batla.
Okay. I just wanted to add, prolonged labor should be discouraged. So if there is no progress, we have to, active management is more important, because we can't let her go through 18 hours, which means we are going to go through 2 sets of nursing staff and cleaning staff. This again is very important. So very prolonged labor, for example, and a VBAC, etc. We've stopped giving VBACs for this period of 2 months. So I think that is also important.
Yeah.
And one thing I would like to add is that, Nozer, how about using a depot injection for these, 16-week terminations, all those things? You can use a depot injection immediately?
Absolutely. I mean, why just for terminations? The recommendations even have changed postpartum.
Yeah.
Initially, postpartum contraception using progestrogens had to wait for 6 weeks. The WHO has changed that, and you can actually give them something before they go home. There has been a tendency among gynecologists to think that cesarean sections are the safer way out, and they tend to have a slightly higher C-section rate. Well, my opinion is the advantage of a vaginal delivery is the patient can leave the hospital earlier. And during this time, you do not want your patient to hang around the hospital for too long. And more importantly, the hospital needs its resources, its bed, its staff to be ready for a lot of other things. So do your vaginal deliveries, but as Rekha rightly said, do not push it as we normally would have. Give them the easy deliveries, and if that's not going to happen, accelerate. If that's not going to happen, definitely do a section. Regional anesthesia is probably extremely safe from the anesthetic point of view.
Yes.
A big challenge has come in, Niranjan, and I don't know whether that's for all people. My biggest challenge has come in with hospitals setting their own rules and protocols. Bhaskar mentioned this earlier. We are distressed by the confusing rules and regulations which are changing on a daily basis. Test, don't test, threaten doctors so that they won't test, and I think at the end of the day, basically they want to keep the total number down. So they know the cases are out there, they don't want to know how many there are. But my problem is a hospital insists on a negative report before I deliver the patient. Now that's the most difficult thing to do. How do you time that report? So what I have started doing is I watch patients, I make sure the cervix is very favorable. When they have a good Bishop score, I'm doing my test, and the moment the test result is available, since I have a window of opportunity, depending upon from I've been doing many more inductions these days. Because I had a patient of mine, I didn't induce her, she went post-dated, the test was invalid, and I had to deliver like I would have delivered a COVID positive patient. So these are the practical problems that we are facing in private hospitals, and we have to find innovative ways of dealing with them.
Okay. Thank you, Dr. Nozer. There is one more question from Dr. Aspi Raimalwala. He just called me. He is asking whether vaginal ligation can be done, if not a lap ligation, because laparoscopy we are not trying to do this time. So what is your take on that?
First of all, vaginal ligation would be great, but only an excellent surgeon like Aspi, who's probably done vaginal ligations in his time, would be doing it. I don't think I would. Mini lap ligation is something many of us can do very easily with an extremely small incision. I mean, all of us in our training, at least from our generation, have done plenty of those. I still believe, and I think Rekha has clarified it very beautifully, endoscopic surgery is still a valid option. Endoscopic surgery done with all your due precautions once a theatre start working is something I would prefer to do my laparoscopic ligations if I had to. Local anesthesia, minimal GA or just sedation, a quick in and out procedure. Don't use any cautery, so no bipolar, just your bands. Get the patient out of the hospital within a few hours. I believe that that's a very, very valid technique of ligation at this point in time. I don't think there is any contraindication to that. So I don't want our listeners, our viewers to go back believing that they need to go away from endoscopy. Endoscopy is always going to be a mainstay. We just have to do it more safely.
Dr. Niranjan,
Niranjan, can I come in, please?
Yes, please.
can we?
Okay. Hello.
Yes, yes.
Yeah, I would say that in Calcutta, at least in our hospital, we resumed outpatient services and elective surgeries about 2 weeks back. And that is when lockdown 3.0 started and government sent us a circular saying that please start normal services. Of course, not many patients are coming because of transport issues. And we have started doing our laparoscopies. I think the point that Rekha told us before, that a lot of the worries about laparoscopy are twofold. One is genuine, which is the GA causing aerosol generation. But as far as laparoscopy generating aerosol, a lot of the risk is theoretical. What we are doing is, again, that is our hospital protocol. Patients who undergo GA, they have a twofold screening. They have an RT-PCR as well as a low radiation HRCT chest. I mean, both are normal. We do a laparoscopy. What we do is because we do not as yet have an automated smoke evacuator, everybody's figured out their own jugaad ways so that they let out the gas, go through a hypochlorite solution into a closed suction system. But as Nozer said, and there are patients who are obese, there are patients who've got diabetes, there are patients who are getting hypertensive. We will do open surgeries on them and save them from corona, but they'll die of a thrombosis or they'll die of a myocardial infarct. I think it would be a wrong message to say, do not do laparoscopy absolutely.
Thank you, Dr. Nozer. We go to Dr. Nirja. Madam, are you there?
Niranjan, I think it's great that we are having this conversation because here is Bhaskar, who's resumed work to some extent in Kolkata, in Bengal. Nirja says they've resumed some of their onco work. In Bombay at the moment, I know at the moment we are the hotspot with the largest number of cases. Our hands are pretty much tied. But at some point in time, we are going to have to start our work. And it's very important that we learn from each other's experiences.
Absolutely.
Because I spoke to people at the ICMR, they said these are our guidelines, states can do what they want. The officer at the state changes guidelines every day. And at the end of it, if you talk to them, they just quote the Epidemics Act, which gives them unbridled power, including of punishment, and very little accountability. Because under these acts, anything they do in good faith cannot be challenged by anybody. But I think it's time that states started learning. If Kolkata and Bengal can do it, there's no reason why other states in the country cannot do it safely.
Thank you, Dr. Nozer. Nirja, madam, there is a case of an ovarian tumor. Now she's in early stage. Would you go and operate her post-lockdown?
Yes, we are now taking these patients up for surgery, and anyway, it will be 3 to 4 weeks by the time she will need chemo in case she needs chemo. If she's very early, she may not even need. So either way, I'm sure you will be able to give her good quality.
So all these patients, all these patients will have to go a COVID test before they electively are operated, or only if they are symptomatic, then only you would like to go ahead with and do it.
Our anesthetists are insisting that we have to have the COVID test. So we are definitely doing a COVID test within 2 to 5 days before the surgery. But as I said, we still cannot let down our guard just because the test is negative. We must still be careful as we would be and ensure. In fact, we have procured for our labor room as well as for our main OT gumboots for everybody. So wherever there is a spill, they are wearing not just the usual protections, but they are actually first wearing a gumboot before anything else. And we have also ensured, of course, that they will all wear the face shields wherever we suspect that there will be a spill. But if there is a simple case, an early endometrial, I don't really expect a spill. I will not be wearing a gumboot maybe, but just a normal shoe cover. So that sort of a thing. So you just keep it in mind all the time. Don't forget corona. That's the main message. But I wanted to add one thing about the telemedicine, and I think now MCI is coming up with the online course, and it is mandatory to do that course and be certified for telemedicine. So I think we must keep a lookout for that and do that as well, because there is someone rightly pointed out that you cannot assume that because a patient is calling in on telemedicine that the consent is implicit. You have to let them know that this is telemedicine. It is not a substitute for a face-to-face, but it is sort of a triage to face-to-face. And if someone really insists that they want to come in without that, then I think we should honor that and respect that, and we should allow them to bypass the teleconsultation, not be terribly rigid about insisting on a teleconsultation if some patient chooses not to.
Dr. Neerja, there is one homeopathic medicine, arsenic, which is going around in WhatsApp University. What is your take from AIMS?
There are a couple of homeopathic medicines which are being promoted as being preventive. And yesterday I was on a webinar with the Niti Aayog, where the director of the All India Institute of Ayurveda was telling about various, because we were actually talking about the geriatric group there, and they were talking about various Brahmi and Ashwagandha and Chavanprash even may be helpful. So I think all of these are good things to try out. They don't probably have any side effects if someone wants to try them. But on a personal note, I have to tell you that my mother says that one of these is a very potent anti-inflammatory which was prescribed to her many years ago for an early rheumatoid arthritis, and it never came back. So I'm sure there may be some good in it and they can go ahead.
But definitely not for arsenic.
Not arsenic, this is the other one. I mean, I could send the name to
there is a message from thank you, Dr. Neerja. There is a message from our own Foxian, Dr. Maninder Ahuja, and she has said, Niranjan, we are going to set guidelines for the world now for corona care, and you guys are doing a fantastic job on TOG webinar. So all of you are doing wonders. Though we have passed 2.5 hours now on this webinar, I would like to reiterate here that we have crossed more than 3,200 users being logged in and visualizing you all from SAARC countries, and especially joining us, Dr. Karki, thank you so much, and Dr. Laila. There are few more questions which are lined up, but due to time constraints, I will just take one or two for all of you. Dr. Laila, what would you recommend for doing ultrasound in your country? Doing ultrasound, is it recommended in first and second trimester, especially in lockdown period? This question is from Brazil. The name looks very complicated. Dr. Mark Caraway, please suggest a guidance from you, Laila. Then I will go to Dr. Nauzer.
Thank you very much for the question. Can you hear me?
Regarding Mark Caraway, what do you suggest of doing ultrasound for screening in the evolving course? Yeah.
Actually, for the last 2 weeks, we are doing the ultrasound in our hospital. But for a known case of for COVID patients, they are not doing actually. But when the patients are not,
So for ultrasound, before you go ahead with an ultrasound, do you make mandatory COVID testing to be done, or it is just no?
In some centers, it is mandatory to do the COVID.
Dr. Karki is nodding his head in negativity.
Niranjan, can I come in? Niranjan.
Dr. Niranjan.
Yes, Dr. Karki, and then after that, Dr. Bhaskar, please.
Yeah, sir, you know what happened? The rule of the game, it's not changeable at all. So for ANC, we have to go like ANC. Only ANC classes you can omit, but ANC checkup we have to continue. USG is mandatory. Whenever it is necessary, we have to do it. So, so far we don't ask our patients go for COVID checkup. So far, we were doing just symptomatic only. We have a fever clinic. That's all. So, whosoever comes for checkup, we do routine blood, everything. Then we do ultrasound. We do ANC checkup regularly. We were doing in the past. But each and every time we try to educate our people. Please come to hospital when is there necessary. Otherwise, frequent visit is not mandatory. So you can take a telephone number and call us anytime. We will try to solve your problem by telephone, like a telemedicine.
Very good. So you
Niranjan,
support.
Niranjan,
Yes,
Niranjan,
Bhaskar.
there are a few issues about ultrasound. Please remember that ultrasound is a high risk area because every interaction with a patient is within 3 feet and more than 15 minutes of duration. So ultrasound, the personal protection is very important. Having said that, it is illogical to ask patients to have a COVID test before having an ultrasound, because that way you'll have to ask for a COVID test before a patient steps into a hospital. Our radiologists at some point of time, although the fetal medicine unit didn't want it, the radiologists were getting worried a bit at point of time. We have told them, please use the protection. There is no question of doing a COVID test. If somebody is symptomatic, then please postpone the ultrasound by 2 weeks unless it is urgent. Now, while Dr. Karki said that the rules of the games don't change, but it does change. The reason it changes is because people, each ultrasound is taking double of the amount of time that it was taking beforehand, because of your cleaning of equipment, cleaning of the place, cleaning of the personnel, and that is why, and the screening. And that is why the number of ultrasounds that can happen in our fetal medicine unit has decreased. And that is why you need to prioritize your scans. So initially when the lockdown happened, they were giving priority first to 36-week growth scans. They were pushing back their anomaly scans by 1 or 2 weeks. If after that, if they had a slot, they're doing the nuchal scans. Otherwise, they're telling the patients that please send them for a quadruple test. But then we are past that time. We've cleared the backlog. Now we have again fallen into place. And I guess it will not happen in Bombay so soon. Or maybe we can go to the situation in Bombay in 2 weeks' time or 4 weeks' time. But at the present moment, again, we've managed to resume our ultrasound services to the normal level. But earlier, when we are doing 20 scans a day, now we are doing around 12 scans a day because of the protection and the cleaning and etc. But no COVID test before an ultrasound, please.
Okay, thank you. Thank you so much. I think, Dr. Rekha, you want to say something?
We are also doing scans without COVID testing, and we are going ahead with NT scan, anomaly scan, and in necessary cases, a growth scan. So we are not missing out either the NT nor the anomaly. We are going ahead with it. But like Bhaskar mentioned, we are just doing about 10 to 12 cases, and complete PPE is available for the pulmonologist with a face shield and everything.
Dr.
We miss
Nozer,
the NT scans at the start of the lockdown, no longer.
Dr. Nozer, Dr. Karki, then we go to Swati Manerkar. There is one question to you.
There's also something we use, Niranjan. We use the sheet under the patient, which is a paper sheet, and the paper sheet is completely changed from head to foot after each patient gets up.
That's a very good way of managing cases. Yes, Dr. Nozer.
So at least in our practice, we have our 4 scans, which we've done for our patients right through the lockdown. So we have done the NT scan along with the correction for the dual marker. We've done our 18 to 20 week anomaly scan. We've done our growth scan, and we've also tried to time our antenatal visits with the ultrasound visits, because the ultrasounds happen in the clinic. So we are seeing patients less frequently. They have to come out of their houses less frequently during a lockdown, but they are not. We're not compromising on our 4 scans, including one at 36 weeks. Yes, the somnologist probably has to be more careful with the PPE. In our case, it's basically gloves, face shield, and yes, a gown. They're not wearing a full PPE. And what's happened at the moment, at least for the last few weeks that we are going through this, is since there are no significant gynecological scans, and since we are primarily doing only these 4 obstetric scans, we are giving more time automatically. But when things open up and the disease is still going to be around, then we'll have to recalibrate our appointments. We'll have to do what Bhaskar just told us. We'll have to keep more time between the ultrasounds, more time between our surgeries, so that people can do a thorough job of cleaning. Cleaning, sanitizing, sheets on the table, extremely important. And here I want to go back to what I said earlier. You are being watched like a hawk. Our patients today are extremely vocal and aware. And if they even perceive a kind of carelessness on behalf of our staff or our clinic or our hospital, they will be held to pay. So these protocols are not just clinically important, but they are also important as far as perception is concerned. And you cannot switch this off and on. Put signage up which tells patients that don't worry, this surface has been sanitized before you went on. Put that sheet under to make a very, very strong statement saying you're thinking about her. The covers of the ultrasound probes are very important. Seeing a doctor in a face mask and a shield is very reassuring for these patients. So we are going to have to work this at multiple levels. But at the end of it, for the good of our patients.
Dr. Swati, thank you for your patience and being there with us, waiting. We, as you know, we are all gynecologists and obstetricians, and once we enter something, we just don't come out with those things. But obviously, we are very elated and happy to see those babies crying, and really mothers being so happy that you're delivered, and there is no vertical transmission. So any precautions would you advise, or any investigations for these babies or neonates to be specifically to be done? Shobana Shinde has asked this question to you.
As per the present guidelines, if the mother tests positive, we do test the baby, and most often we found that the baby is negative, but a very, very small number we found the baby tests positive. So far, there isn't enough data to support any investigations in the baby if the baby is asymptomatic. And so far, we haven't really come across symptomatic babies. Because of the coronavirus, they do have their routine neonatal morbidities, prematurity, perinatal asphyxia, and other things. So far, nothing in literature to support any specific investigations to be routinely done with the babies who made test positive. Just breastfeed is my message.
Okay, thank you. Thank you, Dr. Swati. Dr. Neerja, you have asked one question. Do you support during doing fewer antenatal visits in this time? So obviously, Dr. Neerja, can you unmute?
Our thinking that we need to, try and see how often to call the patient. Previously, we were calling them far too often, I think, which now that we are allowed the feasibility of teleconsultation, maybe some of those visits need not be in-person visits, or some of those visits, if she's already been to the ultrasonographer, if she has a way to get some routine testing herself of her BP, recording her weight, doing those kind of routine things, maybe we don't need to call them each time to see us. So I think we need to work out on an individual basis how high risk the patient is, and how many times does she really need to come?
I think absolutely. I think if you have a facility like Noza said, where the ultrasound and the consultation happens in the same place, then you can time your antenatal visits along with the ultrasound visits. If you do not have that facility, I feel that a lot of consultations can be converted to video consults, and you can really reduce your number of antenatal visits significantly.
That's what I think we have to be all safe, try to understand that it's only when the patient goes in labor or the patient requires any emergency help, please go at that time. Don't just waste your time in seeing so many cases unnecessarily, unless they are to be delivered, and unnecessarily they have to be seen by you. Only when you have to do an ultrasound or you have to do a procedure, better be geared up at that time with all the precautions being there. Yes, Dr. Nozer, I'm going to...
So we have certain, importance of antenatal visits. And like Neerja very rightly said, it's time to do everything. You don't have a choice. All of us work with consulting rooms which are full to the brim and overflowing. And a large number of patients coming are patients who come for their monthly, fortnightly, weekly antenatal visits. We will have no choice if we are going to decongest our consulting rooms so that there can be proper spacing, so there can be all the protection of patients, that we will have to see the patients less often. But we will also have to be extremely vigilant, because if you're going to delay your visits too much, we could be missing an IUGR, we could be missing a severe hypertension. So let's not forget that obstetrics. So we are going to have to do things very cleverly. We are going to have to triage just patients who are COVID and non-COVID. We are also going to have to triage our antenatal patients with a lot of vigilance. The bare minimum that we do is important. So we do 12 weeks, we do 18 weeks. If the patient is high risk and needs it, elderly, whatever, I would normally call her once in between. But the next visit, I might try and delay by 6 to 8 weeks. And after that, I'll call her at 36 weeks. That's when I start seeing her more frequently. And the reality is, I know we're all talking about COVID testing. We are not allowed to test an asymptomatic patient. Okay? This is under threat of punishment. At least that's what's happening in Maharashtra and Mumbai. So it's all very well to say test a patient because ultrasound, whatever. It's not allowed. Yeah. And the labs are not allowed to do it, even if patients are willing to pay. And people initially went overboard. But that's the time when I need that COVID test to get my patient into hospital so that I can time my delivery, particularly if I'm planning a vaginal delivery, I will have to see her more often. I have gone back to the good old strippings. I do my test. It takes 24 to 48 hours to get the test done. It may take another 12 to 24 hours or 48 hours to get the report. And then I've just got another 2 or 3 days in which to deliver her. So we are going to have to practice our obstetrics, adjusting to rules, regulations, lab tests, lab appointments, and COVID reports. It's changed.
Sir, wonderfully explained the way you have explained how a private practitioner in Mumbai or in any metro city which is in red zone can do all these things, but has to follow the rules and regulation of that particular state and see that you protect yourself at the same time you get the best treatment to your patient. Sir, one last question to you, then I'm going to Dr. Leela, and then we are going to end this session. There are 20 more questions, but we are gone beyond 2.5 hours. This is the record for TOG webinar where more than 3,300 members are still logged in, seeing from east, west, north, south of India, and obviously our neighboring countries. Sir, I want one question to be asked to you. Do you wear 2 gloves or 3 gloves while doing stripping or ARM?
No.
No need.
I don't.
Dr. Leela.
Now, I want to say something here. I'm concerned about paranoia. I did an MVA.
Sorry.
This was a patient who had been tested and was COVID negative. And because of the hospital policy, we used 4 PPEs, me, my assistant, the nurse, and the anesthetist. You know what other countries have faced when they needed PPE for the real frontline workers in the real high-risk situations? I know that there are municipal hospitals in Bombay, when they need PPEs, they are not available. Let's not be wasteful as far as resources are concerned. I think Rishikesh showed that one slide today which told us exactly what we have to do in different situations. In an OPD situation, minor procedures, major procedures, and prolonged procedures. And I think basically we need to follow that. Be safe, be careful, don't be paranoid. Do not be wasteful. It's not about cost. It's about the fact that this is a very precious resource for your country. We are going to see many, many more COVID patients. The peak is nowhere near. It's going to happen in the next few months. And all these things are going to be required by the young people, by the people really on the front lines, dealing with the ventilators, dealing in the ICUs. And I don't want a time to come when they have to compromise on what they really require.
Dr. Karki, then we go to Dr. Leela.
Dr. Nirendra, just simple, I just want to add one thing. I'm slightly disagree what doctor has said. You know, being a surgeon, you know, I want to recommend each and every surgeon, whether they perform open or laparoscopic surgery within the time of COVID or without COVID, always try to wear 2 gloves. 2 gloves is always safe. Even you prick it one, by all means using 2 gloves, it doesn't cost much. So, because from the very beginning of my practice, I wear 2 gloves. So I do recommend all my juniors also, please try to wear 2 gloves. It's not because of COVID, not because of HIV and other things, because God has given 2 pair of eyes, right? 2 nostrils, 2 kidneys, right? 2 lungs. Then it's, you go with 2 gloves, that's always safe. 2 gloves, right? I'm not 2 masks. And mask also, there should be at least minimum 3 layer mask. 2 layers, it doesn't work. There should be 3 layer, and if possible, there should be a filter also. Otherwise, you go with N95 or so many new terminology. I have never heard in my life about N95 or things. Now we are gradually knowing a lot of things about the mask, now gloves also. But my request, wear always 2 gloves.
Thank you, sir. We have understood what you want to say. Everything is in pair. Yes, Dr. Nozer, we go to Dr. Leela.
Your question was vaginal examination, stripping and ARM.
Yes.
And again, I said, don't be paranoid. They have not yet identified the virus in amniotic fluid. They have not yet identified the virus in vaginal secretions. I'm going to stay sensible to that practice. We are not talking about surgery here. We are not talking about using sharps and using needles. We are talking about a vaginal examination with a stripping, a vaginal examination with an ARM in a situation. I do not expect there to be a virus.
Thank you for your opinion. Thank you so much. Dr. Leela, can you unmute your mic? That's the last question. Dr. Leela, can you please unmute your mic? Thank you. The question is about whether HCQ is a curative medicine now for COVID-19. This is by Dr. Vijay Pangrekar. COVID-19 HCQs which we are taking, the healthcare workers, or the medicines which we are giving now to the patients. Can HCQs be used as a curative medicine in COVID-19?
Yes, in COVID positive patients, in COVID positive
just variants because we are not using medicine for prophylactic use. But in the hospital, they are trying all type of medicine, you know, azithromycin and the antiviral.
Evermycin, antivirals, that is what is to be done.
But not as a prophylactic use. And the another question is that during operation, we use 2 double gloves, but not during the amniotomy. That is during the rupture of the membranes.
Thank you, all of you. There is a message from Mr. Samar Ghosh. He's the Senior Director of Encure Pharmaceutical Limited. He has sent a message to all of you. We are indeed truly privileged having all of you in today's TOG Foxy platform. Warm welcome and good evening. There are many messages. Dr. Pal, I think he has just dropped out, but hopefully we can see him here again. Dr. Bhaskar Pal is also there, and we have all the stalwarts who have come here, and I hope everyone has enjoyed this wonderful presentation. Is Dr. Om there online? Is he there online? He would like to say some few words.
Yes, sir. I'm
he's
there.
medical director. Who is the medical director of the Encure Pharmaceuticals? Then we will have the videos on. Can you unmute your? Can you please unmute? Yeah, thank you.
Yeah, I hope I'm audible.
Yes, we can hear you.
Yeah, good evening, sir. I'm Dr. Omkar Swami on behalf of MQ Pharmaceuticals Limited. Thank you, Foxy, for providing us an opportunity to collaborate for this wonderful event today. We also extend our deep gratitude towards esteemed faculty who really made this program very interesting and lively to a larger audience which are attending virtually across the India and outside the India. A special thanks to our moderator, Dr. Niranjan Chavan sir, who make this program very interesting, reaching out to each and every faculty and taking their opinions, which was a true success. At the same time, we feel that our endeavor has always remained as a preferred healthcare partner when it comes to Foxy. With the same endeavor, we would like to work in future as well. As a token of gratitude, we are playing a small video which we have listened at the beginning again for the one more time, and I hope everyone will like this music once again. Thank you very much and have a nice evening ahead.
Thank you, Dr. Omkar, and I would like to present a vote of thanks. Each one of you have been so wonderful, given your precious and valuable time from East, from West, from South, from North of India, all big luminaries spending 2.5 hours sitting with us. In spite of your busy schedule, you have come all the way, and obviously our special guest, our HOD from Neonatology Department, Dr. Swati Manerkar, who has delivered so many COVID patients, and we are just going to work on that. Obviously, Dr. Laila, thank you so much for joining us. Dr. Karki, you have been wonderful, being nice. We hope to see all of you in person very soon. Dr. Rekha, Dr. Nirja, Dr. Nauzar, and Dr. Bhaskar, Dr. Basab. Rishikesh has just left, and thank you so much for him to join. All of you, be safe, be happy, and be kind, be nice. Thank you so much, all of you.